So good morning, everyone. Thank you for joining us for this morning session on Saturday before going on the weekend. We are happy to give you some good vibes, especially in this particular situation, which concerns lots of countries being on lockdown. But we are here and you are not alone, so we are happy to provide you some shockwave update today, this morning. So for those who don't know me yet, so my name is Mary Christine Collette. I'm an education specialist promoting the Swiss DolorClast Academy. So what is the DolorClast Academy? It's the educational platform offering shockwave training programs, whether they are physical or online. So we provide shockwave training programs to practitioners who are interested to become shockwave experts and who would like to offer the best for their patients in their practice. So today we are welcoming Daniel Morgan, our sports chiropractor, but he will introduce just a bit later. Just before going on with this webinar, just a few technical points. If you want to ask questions, comments, suggestions, please use the Q&A or chat sections and we'll be very happy to answer them during the course of the webinar or at the end as well. So Daniel, off you go.
Great, thanks MC. Let me get the keynote up. How do I present this? Put it into presenter mode. There we go. Okay. So as MC said, I am Daniel Morgan. I'll run through a little bit about the Swiss DolorClast Academy before we begin. So the Swiss DolorClast Academy offers obviously the kind of tailored training programs really, and it's a worldwide academy. We hold over kind of 200 courses a year. There's 70 official trainers from 24 different countries, and it's led to over 5,000 certified practitioners in more than 30 countries. So this, although kind of myself and a few colleagues do it in the UK, this is a big it's a big kind of mission that the Swiss DolorClast have to get the best standard of training and the best quality of training across the world, really. As I said, I'm not the only DolorClast trainer. There is 70 official trainers across the world. So what do you get from joining the Swiss DolorClast Academy? You have a place to register your online practice. So if there's anybody that is looking to refer potentially, or if there's patients that are looking for somebody who offers shockwave, there is almost a map where they can find your clinic and you will be listed as a registered practitioner in shockwave therapy online. Certainly in the UK, we have a Facebook page as well, which Chris has set up as a DolorClast users kind of Facebook page, which I think now is a shockwave page, specifically for any questions where myself, Johnny, a few of the other trainers are on there. So if there's any concerns or any questions regarding that, we can actually kind of get back to you relatively quickly on there. So have a little look and try and get certified if you can. It is a big benefit towards the practice and yourself as a practitioner. So it really helps you increase your exposure, and it can really drive business a little bit as well. Now today, the contents of today, what we're going to do is we're going to look at the history of shockwave therapy a little bit. We're going to go through the physics. So what is shockwave? What are shockwaves? How does shockwave therapy work? What's the theory behind that? The indications, the precautions, the contraindications for care. So this is a really important one for those of you that are new to shockwave therapy. What works and what doesn't. Certainly, I can give my anecdotal experience there as well. But we'll go from the literature, we'll go from the PEDRO database, and we will also really, when we come into the practical sessions a little bit later on, I will kind of explain what I would do during my treatments, as well as kind of run through a little bit of the literature during the content section here that we're running through. And then obviously we do the practical where we get a lovely body in, so that we can then just kind of show you how I would typically do it in practice for all of the conditions that we've discussed. So a little bit about me. I'll quickly skim through this. I am a chiropractor by trade. I work at Beaches Chiropractic in Port Talbot. Beyond that, I've studied a master's in sports exercise medicine, and I am also a MSK sonographer. So thankfully, we're in a position that we can provide a scan and treat within the first day at the clinic here, which is great. I've won a couple of awards as well during my time. I was British Chiropractic Association of the Year in 2018. And more recently, I've picked up a post in the Royal College of Chiropractors Sports Faculty as the Director of Academic Affairs. So very much like MC is responsible for the CPD within the Swiss DolorClast Academy, I am responsible for the CPD within the Royal College. But that's just a little bit about me. To the right hand, to the right hand side of the screen, there is a photo of myself and Marilyn Coro. She is a Olympic bronze medalist and a EMS success story. A colleague of mine, Johnny Rides, treated Marilyn, and she was struggling with her Achilles, and we're able to discuss this openly as she's discussed it openly. But she was struggling with her Achilles, and she wasn't doing very well. Johnny was able to treat her with shockwave, and it hadn't been suggested previously. And as a result, she returned to her sport, which was sprinting and relay, I think. And she won a bronze medal in, I think it was London, but it might have been prior to that. So yeah, she's obviously a lovely success story. And more recently, some of you may have seen some more testimonials that we're trying to put out as well, with certainly its use in elite sport. Liverpool being there, Saracens are up there in the UK. Both of these are avid users of the Swiss DolorClast. And the big one that circulates now and again is Neymar with Barcelona. So, we have an abundance of clientele that are not only weekend warriors, as we call them, but elite athletes as well. So that's a little bit about me. Now onto the good stuff. So we're going to get into the history of shockwave therapy, and firstly we'll go from how shockwaves were discovered all the way up to the present day, which is going to be with the DolorClast Academy. Now, the discovery of shockwaves was in the 1940s, and it was pretty much during World War II. And soldiers were experiencing internal injuries with no signs of external traumas. So there was no cuts, there was no bruises, but we were experiencing things like particularly injuries to the abdomen and the lung field. So there was things like pneumothorax and potentially kind of bowel injuries, because we then started to query, okay, well, what do these areas have in common? And that is that they're air-filled regions. So this is quite important at a later date when we come to taking precautions with certain treatments and certain areas particularly, and also kind of treat it, yes, particularly contraindications to care in these areas. Now, from a testing perspective, it was very, very early days in the 1950s where we wanted to see what we could do with shockwaves. And the initial thing was to pretty much break things. We were there to try and destroy things with shockwaves. Laboratory experiments were shown to break down ceramics, and they could, happily break those comfortably. And this then led to an increase in interest in shockwave therapy, and particularly could it be used in medicine. Now, the way that we use shockwave now is a little bit different to how it was then. For some reason, it was decided that shockwave therapy, we used to use it in a water bath. So we used to have the handpiece in a water bath, and that would then be kind of applying shockwaves straight through. Now, for safety reasons, obviously electricity and water doesn't mix for some obvious reasons quite well. And we now no longer use water baths, but we use a contact medium, and I'll discuss the importance of that contact medium in a little bit. But yeah, that was its original use, was to break things really, and even in medicine, that was its original use, was to kind of looking at destruction of potential things that may be harmful. So again, I'll get onto that in a minute. Then in the 60s and the 70s, we kind of looked at more animal testing. So the German Department of Defense researched the effects of shockwave therapy on animals in particular areas, and they were particularly interested in the level, the high energy shockwave therapy and its effects over distance and the side effects as it passed through certain tissues. So it had key areas that they were interested in were the lung, the brain, and the abdomen. And again, this is very similar to kind of the injuries that we were seeing during World War II, was that we were getting a lot of pneumothorax, maybe a lot of abdominal issues and brain areas. So they were shown to have low-level side effects with using shockwave therapy in those areas. So this is why, again, when it comes to the contraindications, we tend to stay away from those, but I'll discuss that a little bit later on. But yeah, that's why we were aware of the low-level side effects, is that unfortunately these studies were done on animals in the 60s and 70s. And then we went into the 90s, 80s, 90s really, where we went into human testing. And the first reported case of non-contact disintegration of a kidney stone was with shockwave therapy in 1971. And in 1980s, certainly in 1980, the Dornier lithotripsy HM1 treated the first patient for kidney stones. So remember I was saying that in its early kind of phases, we were looking at destroying things. Well, this is how we first used it to destroy things in medicine, was that we were trying to disintegrate kidney stones with non-contact methods. But then obviously that led to a particular interest in musculoskeletal conditions. And it was particularly looking at heel spurs and epicondylitis initially. And also I think there was a lot of non-union fractures as well. So we were kind of looking at the scaphoid fractures and not just non-union fractures in general to see what the effects of shockwave could have on those. And heel spurs, epicondylitis, there's an abundance of literature out there now actually in these. And if you look particularly in the foot and the ankle, that's where the majority of the literature is carried out, and that's where the majority of the evidence is. So from the 90s onwards, we've been gathering data on these conditions. And the PEDRO database is now a collection of those studies that will give us the kind of the best treatment options, the best outcomes. So we'll discuss the literature a little bit later. And that kind of brings us to the present day, which is you guys. And normally I would have a video on at this point, but I'm not sure if you'll be able to hear the sound. But it's just an introduction. It's a little Swiss DolorClast Academy video. And we'll see if it works. I can hear the sound. I don't know if you can. Yeah, I didn't think you guys would have a great deal of sound with that one. So that video is online. You can see that video. You know, it's nothing special really. It is just it's a video that you can actually access via YouTube. So let me just try, and I've just opened the chat box, and it's currently in my screen, and I can't really get rid of it. So give me a second. There we go. Okay, so what are shockwaves? Shockwaves are high pressure sound waves, and they differ to other sound waves as they are high intensity waves generated at extremely high pressures. So day-to-day examples of this is the airplane breaking sound barriers. Earthquakes, they produce primary shockwaves, secondary shockwaves. We also have explosions, and explosions is how we can show the effects of shockwave quite easily day to day. So this is a little video. Again, there's no sound with it. You don't need the sound. It's more of a visual demonstration of how an explosion has an effect through air and through water. So this is the importance of the contact medium, which we'll come on to. Now, the key thing, and this is exactly what I mean, is that shockwaves have very little energy dissipation through water, which means that energy is lost very little in water. And that is why we use the contact medium. So if you guys can see me in the camera, this is the contact medium that we use, which is an EMS contact medium. Ultrasound gel is also fine. The EMS contact medium has less air bubbles in, so it's meant to dissipate that energy slightly less. But ultrasound gel for the most part works fine. So to give you a visual representation of this, the white ball on the left here is a charge, is a detonation charge. We also see water balloons placed on the ground. Now, these are equal distance apart, and what we'll see is how that energy is lost throughout distance. So as you can see, certainly the first 3 balloons have been destroyed, whereas the last 3 aren't. And the ripple that we see on the right balloon is significantly less than what we see on the orange balloon there in the middle. So it's fair to say that energy has been lost as the distance increases. And this is a little bit different to what we see with water. Now, there's the original charge. And then there's a second explosion, which is, it's actually a part of the normal shockwave physics. But through the distances, the energy doesn't really differ a great deal. So this is the importance of using shockwave in a contact or a water-based contact medium, and with as little air bubbles in as possible, really, because if we have more air bubbles, that's going to lose more energy. So it's going to lose energy as it obviously penetrates through the structures that we are looking at. Now that is what we mean. So if you can have a look at that again. The effects are obviously pretty equal throughout because of the water that it's embodied within. Okay, so this is what a shockwave looks like in terms of physics. So if we look at pressure and time on the x-axis and pressure on the y-axis. Now, there's 4 characteristics. It has a very high positive peak pressure, it has a very fast rise time, it has a negative pressure, which is number 3, and then it has a very short life cycle. So what that basically means is that all of this happens over a very short time frame. The high positive peak pressure is important. This is where we have the compression element of shockwave, and which is the first explosion that you see during that video. And then the negative pressure and the negative energy density is point number 3, and that's that second bang that we almost see. So those 2 flashes that you see in those videos, that represents a positive pressure and a negative pressure. And that's how it looks from a physics standpoint. Now, from a ultrasound standpoint, how does that differ? Ultrasound is more of an oscillation, and it has significantly less energy. It's a longer life cycle. And the ultimate difference is that it has less physical effect on the medium that it passes through. So in this case, it's going to be the tissue. Now, again, like ultrasound, ultrasound doesn't lose energy through water, but because the energies that we are able to provide are higher, we can have more effect on the tissue in general. So if you can recap the differences between that is a shockwave physics and this is a ultrasound kind of wave. So there's a slightly different appearance, less of a peak force less of a fast rise time, and it's more of just ultrasound is more of an oscillation. And we often get asked this on a few of the courses that we've done, so the differences between. Now, there's a couple of types of shockwave therapy or shockwaves, and shockwave is an umbrella term, and it covers both focused and radial. And the only thing that's different is the delivery, so how it's delivered. So we don't use a radial shockwave device; we use a focused shockwave device, which would be, in this case, the DolorClast. And the power is different as well, so they can actually achieve higher energies with focused. Now, the way in which the energy is delivered is quite different. What focused is very much as it says on the tin. It starts very broad and narrows in towards its target, whereas radial radiates and has this torch-like appearance. So it starts very narrow and then goes wider within the tissue depth. Now, what that basically means is that when we look at it from an evidence perspective, there's actually no greater evidence for focused shockwave versus radial shockwave in the majority of musculoskeletal conditions. And in fact, one of the indications for going for focused shockwave would be if radial shockwave treatment has failed. So it just means that we can get higher energies into the tissue, but also EMS have the power red handpiece, which is able to deliver up to 0.4 EFDs, which is double what the DolorClast Blue does. So we do have other radial options to be able to increase energies into there without going down a focused avenue. But yeah, there's two different types. I tend to focus mainly on radial, and that's what I use day to day in clinic. But just for you to be aware that focused is also available on the market, both by EMS and other production companies. Now, the settings that we use, and this is something that you'll see if you are reading the literature on shockwave therapy, this is something that you'll see. You'll either see the energies being presented as bar, which is what we look at things on certainly the new radial shockwave device. It's represented as bar, but in some of the literature, it can be measured in millijoules per millimeter squared. Now, what that is and how do we define that? It's the maximum power that is delivered through a defined surface area, and this is very much dependent on the applicator size, which I'll come on to in a minute. But it's represented as pressure or energy on the machine. So if you have a classic touch unit, you can actually convert that quite nicely. And that's quite nice because sometimes the literature will say, okay, we provided 3 bar of energy. Other times the literature will say that we were providing 0.12 millijoules per millimeter squared, for example. So there is a converter chart for that. One of the other things that we look at is obviously the frequency and the number of shockwaves that's defined as the number of shockwaves or impulses that is delivered per second. And the machine typically will provide between 1 and 20 hertz. Now, the new DolorClast radial device here can go up to 25 hertz. So we can actually provide more energy quicker. And that's something that is quite important. It works on more of a superficial time frame, but equally, if you have people who are in a rush, we can try to increase that frequency a little bit to get them out quicker. And obviously, we can increase and change the number of impulses or shocks that we would provide during a treatment. And normally, for me, it would be around about 2,500. Sometimes you can use a little bit less. Sometimes you can use a little bit more. It does depend on whether or not we are doing trigger point treatment as well, and that will really ramp up the number of impulses that we would use per treatment. But as a whole, I tend to use around about 2,500, maybe 2,000. So it will be in between that 1,500, 2,500 mark impulses generally for treatment. So this is the machine settings that we would see on the Master Touch. As you can see, there is pressure, impulses, frequencies, and the applicator size. And now that's a lovely sliding scale, and it can just be quite an interactive interface, really. The pressures will go from 1.5 all the way up to 4 bar, which will deliver up to 0.18 millijoules per millimeter squared. The impulses will go up to a maximum of 10,000 impulses, and the frequency will go anywhere between 1 and 20 hertz. Now, the applicator size, remember we were talking about that conversion from millijoules, from pressure and bar to millijoules per millimeter squared. If you can see on the bottom right-hand side of that screen, there's an energy button. All you need to do is press that energy button, and that will immediately calculate the energy that you were delivering, or the maximum energy that you were delivering into that patient based on the applicator that you have selected. So that's quite a nice one for you in terms of if you want a specific setting following the literature that has been recommended or the literature that you've seen. This is the Smart 20. It's a little bit less kind of interactive in its personability, if you were, of the treatment settings that you can have, in the sense that we only have 4, 8, 12, and 20 hertz, but performance-wise exactly the same. We can deliver between 1.5 and 4 bar, which again is going to be the maximum of 0.18 millijoules per millimeter squared. The only difference with this is that there's no touch screen, there's no energy conversion. It is touch responsive, but there's no screen, as it were, and it will go up to 2,500 impulses per treatment. But that's not an issue if you can just add multiple 2,500 impulses. If you needed more, for example, which would be for cellulite reduction or otherwise, really, and even if you were just doing muscle injury treatment, you sometimes use a little bit more. But that's no issue. If it just reaches down through the timer, gets down to 0, you bring it back up and you go again. So no problems with that in terms of the performance. Now, I will also go on to, this is the first time I've had the pleasure of doing this, but this is the new DolorClast radial, and this is how it kind of looks. I've got it next to me. And we also have a few more settings here and a few more things that we can change. So we can do the pressures, the top section here, which we can change, and that is purely in bar on this. The frequency is just below. Now, as I said, this goes from 1 to 25 hertz, and then we have impulses, which is going to go up as far as 5,000 on this one. So again, now we have actually done some anecdotal stuff with Chris Miller up in Manchester, and Chris has looked at the cellulite work, and typically the research would say up to 10,000 impulses. Chris has shown results with 5,000 impulses, so that's giving us good outcomes there as well. And we also have the preset protocols, which is going to be that bottom arrow to the right or to the left. Now, for example, we have a tendinopathy protocol on here. We have an enthesopathy protocol on here. We have joint and bone injuries that we have a preset protocol for, and we have skin issues, so wound healing, etc., that we have a protocol for, and a recovery setting as well, which is going to be like your muscle kind of DOMS and delayed onset muscle soreness. So all of that is on here. We also have a muscle setting as well. Now we can change this a little bit to get an analgesic ramp up at the start, which you have section 1 and section 2, and the same with a ramp up, which is you can start relatively low and it will gradually increase for 500 impulses or 1,000 impulses. And then the second setting, which is the one that I use most of the time, is that it just keeps on going until that you've changed and you reach the maximum impulses for your treatment and for your patient. So what I mean by that is if you start at 1 bar and you put the ramp setting 2 on, by the time that you've finished your 2,500 impulses, you may be closer to 2.5 bar. And it is a gradual, very gradual increase, and that is just by the touch of 1 button. And we can do that quite nice. Now, you do also have burst mode on here, which is 1 and 2 again. So we have 2 settings, and burst mode will sporadically get you a quicker frequency in your treatment. Again, that's just to kind of mix it up a little bit, get a change of stimulus throughout the treatment so that the patient can get kind of more of a varied input from the machine. So you have all of those, which is a little bit more, again, more interactive, more personal than the other 2 units. And from a performance perspective as well, there is no change in the handpiece. In fact, it's better. The handpiece is pretty much providing more consistent energies across the frequencies. And when we're looking at the higher frequencies up into the 25 hertz, there's no energy drop off really compared to other competitors out there. So there is kind of handbooks out there that will be able to explain all of that in detail. For me, mainly, I want to just get you familiar with the units and the interfaces, but from a perspective of the performance, Chris will be able to answer more questions on that. Now, I have the applicators with me, so I'm going to actually just see if I can bring myself to full screen for a minute. And I'll stop sharing so you guys can see this. Okay, let me go back to the Zoom. Where are you? There we go. Okay, so we have typically within our handpieces with the certainly with the Evo Blue handpiece and the Master Touch and the Smart 20, they come as a 15mm applicator and a 36mm applicator. Now, this is important. Remember I said that earlier on the energy is massively dependent on the applicator size. And this is because it has a larger surface area. So this has a 4 times larger surface area than this one. And therefore the energy is divided over a larger surface area, which means that per millimeter, we are delivering less energy. Now, that is where, selecting the handpiece is quite important. Or selecting the applicator size is quite important. We tend to use this for a lot of soft tissue work and muscular work, and this then is used for most of the majority of the tendon work. This is also used for the wound healing stuff as well and the cellulite stuff. Now, let me go back to my screen share. Just got to find my PowerPoint again now. Where are you? There you go, got you. And play. So that's the key differences there. Now, I haven't got any photos of the new one, so I would rather show you on screen yet again. Now, we actually have this very similar 15mm applicator that is, when you compare to the previous, the change in color and pressure. The other thing that is different about it is that it's only a dual turn to screw on. So it's just quicker to get on and off, really. Now, this is a completely redesigned applicator that we would use compared to that one. So as you can see, it's larger. It has a completely different depth, and otherwise pretty much exactly the same. Obviously, it would deliver less energy than this one yet again. But it is quite comfortable for the patient, particularly at enthesopathy kind of style things and treatment around about the bony junctions. But again, it's more comfortable, but then do you compromise performance as there is less energy going through it than with the 15mm? So just for you to be aware, we now have a range of kind of applicators that we would use, and it depends on the unit and the machine that you have. Now,
Daniel?
Energies. Yes,
Daniel?
yeah, one, MC.
Yes, we have a question from Louise about frequency, and she's asking why would you use less frequency if you say 25 hertz is best? And also, how do you know how many impulses you need for a patient? When would you use 5,000 and when less?
So frequencies, 25 hertz isn't the best. 25 hertz is just the kind of the maximum that we can achieve. What we tend to use for the majority of treatments is anywhere between 8 and 12 hertz, to be honest, maybe even up into 15. Now, what I would use as, if you can imagine, my way of thinking about it, and this is certainly true with diagnostic ultrasound, if we have higher frequencies, we would focus more superficial. So we would look on more superficial structures, whereas if we have lower frequencies, we are kind of penetrating a little bit further. Now, we can see that as a rule of thumb, we would use kind of 1 bar would kind of penetrate 1 centimeter of depth within the tissue. And the frequencies are there purely for comfort, really, for the patient, I would say. So higher frequencies are more comfortable for the patient, but then we can sometimes, if you can imagine, you try to punch a punch bag. So this is an example that we often use. If you try to punch a punch bag at 1 punch per second, you can use more energy to get there. Whereas if you have to try and punch it 10 times per second, you're just going to go really quite close to it. And that's the difference within the frequencies. So realistically, we don't compromise energy, but we can sometimes get a little bit of a drop off, certainly towards the higher end at the 25 hertz. The energy sometimes drop down a little bit. Whereas in comfortable range, which is 8 and 12 hertz, we know that we can deliver comfortably the maximum energy flux density max, which is what we're going to show. So the EFDs are pretty much for 12 hertz, and we know that that is kind of anywhere between 1 and I think it goes up to 18 hertz. I think that we can show very comfortably delivering 0.1 millijoules per millimeter squared, whereas towards the higher end, those energies drop off slightly. So 25 hertz isn't the best, just to clarify that. That is just the maximum that we can achieve, but with very little energy loss compared to other competitors. But for the majority of tendinopathy treatments and musculoskeletal treatments, they will be between 8 and 12 hertz. And this is based on literature, really. So we know in the evidence that this is what the majority of the methodology is saying and showing. So don't think that just because we can apply more that it's better. Certainly from an energy perspective, we know that the more energies that the higher energy we can deliver, the better outcomes we have. But frequencies is purely for comfort for your patient, and maybe if you're working on more superficial structures, because if you can imagine it's a superficial structure and you're really using the maximum energies that you can possibly deliver into that, it's going to be a little bit uncomfortable. So if we can increase the frequencies, it makes it more comfortable for the patient. It works more superficially, and that is kind of the goals then. Does that make sense?
Perfect. Thank you very much for this complete answer.
No
Talking about frequency, we have another question from Deirdre van Herden. Is the amount of hertz being used also dependent on the stage of injury and or healing?
So it depends. Like for me, I use the majority of this on chronic patients. Now, obviously, when it comes to the GDT protocol, we can mix that up a little bit. I will tend to keep mine consistent regardless of the stage. I think that we know that optimum performance is between kind of 1 and like I said, 15 to 18 hertz. We know that optimum performance and optimum energy can be delivered between those frequencies. So I tend not to change it a great deal, regardless of if it's acute or subacute. The only thing I change it for is pain tolerance, really. So if the patient cannot tolerate lower frequencies, I'll increase it. If the patient cannot tolerate kind of your 8 hertz, then I'll increase that to 12 and maybe up to 15 if they can't tolerate that. What I will say is for muscle injuries, we do use the higher frequencies for the acute muscle injuries. I will get on to acute muscle injuries in the more recent research that's been carried out in that, which was in February 2020. And I'll get on to that when it comes to what works section. But yeah, there's no reason why you can certainly, from a tolerance perspective, that's the only really reason why I would adapt the frequencies.
Perfect. Thank you so much.
That kind of coincides as well with the superficiality of the treatment or the nature of the pathology. For example, if we are looking at enthesopathies, I wouldn't want 1 impulse per second on my calcaneus for a insertional Achilles. That's going to be very, very painful. So if we can increase the frequency to make that a little bit more tolerable for the patient, but still not compromise the energy that we deliver, no problem. That's the real reason why the frequency is so interchangeable.
Okay. Thank you very much, Dan.
No problem. And the other option that you have again with this, and this is where we actually come on to, and it ties quite nicely, and the other option is that you can actually use the larger head. Now you do compromise the energy delivered with a larger head, but it is more, because there's less energy being delivered into the tissue, it's more tolerable. But sometimes you just need to get people introduced to the shockwave initially, and we can get them quite okay with having because it is uncomfortable. Shockwave therapy is uncomfortable to receive. So if we can get people a little bit more au fait and okay with the treatment, use the larger applicators. get them used to that feeling, but you won't probably get the same outcomes unless you're using the 15 mil. And that's where the abundance of the literature is, and that's where the majority of the research would use. We do tend to use the larger applicators when we run up into the muscular-tendinous junction, whereas I still use the 15 mil for trigger point therapy, etc. So as you see, here's a conversion chart that I was talking about. So 2 bar will deliver 0.6 millijoules per millimeter squared, and 4 bar will deliver a maximum of 0.18 millijoules per millimeter squared. Now, if we convert that to the 36 millimeter, it is a significant reduction in energy. And this is why we don't get as good outcomes when we're using it on the tendinopathy side of things, not specifically. Now, you can use this for an analgesic. And again, this is one of the other things that you can do. So if you look at the analgesic setting on the unit, that is going to come up into 25 hertz 1 bar for 1,000 impulses. So that's the other aspect of it, is this hyper stimulation where the increased frequency comes in. So if we hyperstimulate that tendon, it almost numbs it a little bit. And that's where you can get increased pain tolerance again. So again, you can use that with a 15 millimeter, low energies, high frequencies, which would just act as a lovely analgesic, or you can use it with a 36 millimeter, and you can just do a little bit higher energies, but increased frequencies again. So there's plenty of options, and there's ways that you can do it. The beauty of obviously the new radial device is that analgesic setting is preset. So it's ready, you just press that and it'll change it for you. But as long as you know, kind of, you can change the settings on the unit to suit you if you want to do that analgesic approach. It is kind of an old school approach, I guess. A lot of people that have been doing shockwave for many years have been using that. And if it's not broke, don't fix it, I think. So there is definitely ways that you can make it more tolerable, whether or not that's increasing the frequencies, whether or not that's lowering the pressures, whether or not that's changing the applicator size. That makes it more tolerable, but then you have to gauge whether or not there's a trade-off with the energy that is being delivered. Okay, now I actually, what I should say is I haven't got the conversion chart for the 40 millimeter head at the moment, but I'd assume that it is very, very similar, as the surface area is much larger. So it's going to be very similar to what we're seeing with the 36 millimeters, but we can, I'm sure that's been done, and we can get that for you if you do need it. Okay. So the relevance of this, I think that this is the whole point of this, is why is it relevant? What we know is that tendon actually responds between 0.1 millijoules per millimeter squared and 0.2 millijoules per millimeter squared. So with this applicator, with a 15 millimeter applicator, we can comfortably deliver between 0.1 and 0.2 millijoules per millimeter squared. So because of that, this tends to be the applicator that we use for the majority of tendon problems. Now, unfortunately, we can't really get enough energy to affect bone. So that means that, are we going to create a great deal of injury to bone? No, which is a good thing. But then we can use the higher energies for non-union fractures, etc. But we can't get up to that 0.4 with the Evo Blue or the DolorClast Blue handpiece behind me. The Power Red, on the other hand, does deliver 0.4 millijoules per millimeter squared. Now, it is very, very uncomfortable. And to put that in perspective, we actually use that on horses and equine. And they are a lot larger than us, certainly me. So just to put that into perspective, we are delivering twice as much energy as what you do with your Evo Blue, the DolorClast Blue, and with the 15 millimeter head. So that's why we use the 15 millimeter head applicator for the majority of the tendon treatments, is that we know that it responds within those energies. And also what's important with this is that we know that because it responds within those energies, it's safe to use within those energies. So we can't destruct the tendon. It's impossible. The only thing that I would say is that you do need to be cautious as to whether or not the integrity of that tendon. So is there a partial thickness tear that may make them predisposed to tendon ruptures, etc. Now, there's only ever been 2 reported outcomes of tendon rupture in the literature, as far as I'm aware, and they were both on Achilles. And realistically, those patients were very poor patient selection choices. They were elderly, which would have meant that those tendons would have been quite degenerative, and they would have been more susceptible to rupture anyway. So the chances, what we think has happened there is that we've hyperstimulated it. It's created this numbing response. The patient probably feels good. They're able to load that tendon more, and that makes them more susceptible. If that tendon is compromised, they're able to provide more load to it, which makes it more susceptible to tearing. Okay, so just be aware of that. So how does shockwave work? Mechanisms behind the success of shockwave therapy, particularly for tendinopathy, are not yet fully understood, but the evidence is suggesting an interplay between the mechanical effects, the biochemical effects, and pain relief mechanisms. So when we talk about this, we'll show you the mechanical effects here. So this is, again, a representation of a shockwave, the physics of a shockwave. We have in the light blue a positive energy density, which is the compression phase. And this basically causes a shear stress. So it causes the tendons to wobble and shake. Now, we then have this negative energy density, which is the tensile phase, and that produces cavitation. And I'll come into the importance of the production of cavitation a little bit later on. But these are representations of that two flashes that we saw in the explosion underwater. So the first flash is that positive energy density, and that causes the balloons and the cells in the body to compress. And that negative energy density causes them to expand. And it also, there's a second element to that, which is it produces cavitation. And the importance of that is shown in the literature. And we'll also show you how that works now with the kind of shadow imaging. So here is cavitation and a representation of cavitation in a glass plastic, that's a plastic water container, one of these disposable containers. So this is 15 hertz. This is the master, the classic, the Swiss DolorClast classic. They're still in circulation, they're still working very well. So as you can see, the cavitation is very superficial here with the 2-bar. So it's very superficial to the applicator, but it is penetrating further into a little bit further down, but the majority of the cavitation is superficial. But there is more cavitation penetrating further with the more energy that we use. And then 3-bar, same thing. And the key thing here is that the cavitation is being consistently produced across the frequencies. It's not being lost, there's no energy loss. It's been consistent across the treatment. And here is a 4-bar, which is obviously more cavitation, deeper penetration, and higher energies. So that is, how it works. And we often get asked, well, surely that's not the same in the body. But actually, when you look at tendons, the tendon is 80% water. So 20% of it is dry weight. The other 80% is water content. So the rest is made up of collagen type 2, type 2 collagen fibers majority. And that is kind of the difference, is that we think, okay, well, sure, that's okay externally, but actually a tendon is 80% water. So it'll have a very similar appearance within. Let me get on to the next screen. There we go. So this is a single impulse slowed down with shadow imaging. And if you can see that there, we can see the two phases. There's the compression and there's the tensile. So one more. Compression phase, tensile phase, and cavitation production. So we know it matches the physics of a shockwave really well. Now, to slow that down and to put in still images, there is the compression phase on the left at the early phase, and that compression phase continues deeper into the imaging. Now, the late phase here, we have the tensile structures, or the tensile phase of the wave, and compression and shockwave and cavitation is being caused. Tensile stresses are being put onto the tissues, but cavitation is being caused. And what's really important here is the cavitations also, as they burst, they produce secondary shockwaves. And that is the importance of the cavitation. So it's not only the importance of the shockwave being produced from the actual applicator, the cavitation also produces secondary shockwaves. And that's the importance of cavitation. It then creates a greater, wider effect onto the tissue in which it passes through, because if there's no cavitation, there's no secondary shock waves, and that then has a less effect. So make sure, if you are using shockwaves and it's not DolorClast, make sure that your machine is producing cavitation. Okay, so the ultimate effect that this has, it has a mechanotransduction effect. And what that basically means is the tendon adapt to load, the cells adapt to the load that we place on it. And this is the same for rehab. Rehab has the same effect as what shockwave does. Tendons and collagen likes load. So as we are applying the shockwave, the compression phase causes that, the initial phase causes that compression of the cells and the collagen, and it creates mechanotransduction, which leads then into this entire cascade of events which promotes healing. So it induces angiogenesis, which is increase in blood flow. We have this pro-inflammatory effect, so it increases inflammation to the area. It has this immediate pain relief, which is from a neurological standpoint, and then it has long-term pain relief as well. So we liken this to kind of if you eat a really hot chili. It's really hot initially, and then it becomes painful, and then it numbs, and that's that immediate pain relief that we get, and that's due to kind of capsaicin in the chili. So sometimes you can get the heat rubs, which are capsaicin kind of structures, or capsaicin based. But that's how the mechanotransduction works. So from an angiogenesis perspective, the literature is showing that we can get vascular endothelial growth factor increase at the bone tendon junction in rabbits. We increase angiogenic growth factor, again, vascular endothelial growth factors and enos, which are responsible for the induction of neovascularization. And then there's increased activation of proliferating cell nuclear antigens, as well as increased stem cell activation as well. So we know that it has this effect systemically. We also know from a pro-inflammatory perspective, we have this immediate elevation of interleukin 6, interleukin 8. We have a 5-fold increase in metalloproteinase 2 and 5. So ultimately, this leads to increase in tendon homeostasis, it increases fibroblast activity, and kind of just regulates the tendon a little bit. And what this really highlights is the importance of not taking any anti-inflammatories during the course of the treatment, because you're counteracting this pro-inflammatory effect that we want in the tendon, particularly during a chronic phase. So pain management, we know that if we prolong, activate the C nerve fibers for a prolonged period, which happens during shockwave, there's a reduction in substance P and reduced calcitonin gene-related peptide. We have a prolonged reduction of the release of substance P due to hyperstimulation. And this leads to ultimately a reduced neurogenic inflammatory response at the spinal cord. So there is also on top of that, there's a temporary selective destruction of the unmyelinated nerve fibers, and these are the ones that are responsible for pain. So a visual representation of that is the neurogenic inflammatory response is that between the afferent nerve fiber, the first order neuron is sending your painful stimulus, which then the neurotransmitter substance P then selects it to go on to the second order neuron and stimulates that pathway to the brain. We reduce that substance P, which then reduces the stimulus to the brain. And that's the neurogenic inflammatory response that we were talking about. That is pretty much it for the theory. You'd be all glad to know. But if you have any questions about that, I think that now would be a good time to ask. I'm also happy for everyone to take a little break if they want to, but again, we can just go and have a coffee, cup of tea, whatever suits you really. But your call, MC, is up to you with terms of negotiations of that.
Yeah, maybe there are a couple of questions, and maybe after we're gonna have a little break. Yeah, just to have a kind of some movement.
Yes, I agree.
Yeah. We have questions from A question from Hilary. As a podiatrist who's already using shockwave therapy, has anyone tried successfully on Morton's neuroma?
Yes. Interestingly, yeah, I have. We've had very mixed outcomes with Morton's neuroma, but we've had a few real good successes. What we tend to recommend is, the literature actually says lower frequencies and quite moderate energies. Now, I actually like the higher frequencies just to increase the patient tolerance. If you go in kind of into your 4 hertz, 1,000 impulses or 1,500 impulses at 4 hertz, the treatment takes forever, firstly, and it's quite uncomfortable because we are in quite sensitive structures. Now, there's a whole discussion about, is it a neuroma, is it a bursa? And in imaging, they look the same. So maybe this explains why there's mixed outcomes. Because differentiating between a neuroma and a bursa, and are you getting a Gulder's click, etc. I'll give I think it's Gulder's click. We're getting that. What are we diagnosing really? So that's potentially the reason it's a controversial diagnosis, I think, as well. I sometimes will look at an orthotic with a kind of dome, which will offload those medial structures, which will bring you into an arch, as well as kind of combining that with shockwave therapy, and it seems to work quite well with the introduction of both. But I tend to use kind of 1,500 impulses, higher frequencies, so around about 15 hertz, and then just go to patient tolerance with regards to the pressures. We have had good outcomes with it. Certainly, there's 3 patients in particular that I'm thinking of off the top of my head where we've gone, oh, let's try it. And all of them are particularly very, very happy with the outcomes because the next stage was an injection. So yeah, I've done it. We've had good outcomes, but equally we've had non-responders as well. But as an option for care, if you were refraining from injections, it's a good outcome. You can potentially look at a functional orthotic just to look at the dome into the central portion, just to create that kind of transverse arch and get a little bit more of an offload there. But combine those works quite well.
Okay, perfect. Thank you, Dan,
no problem.
for this answer. We have a question concerning maintenance. How often do you need a service for the DolorClast?
Oh.
It depends on the device you have.
It does, and it depends on its age as well. However, I think Chris is probably the best person to kind of answer that one. We in the UK, again, it depends on your location. But we in the UK, I think Spalding take care of the majority of that. So we just pay them and they do it. But I'm really not sure. I think they're annually or maybe by every 2 years, but Chris will be able to tell you definitively. So don't take that as gospel.
And I will check. It's a person who's in Malaysia, so I will transfer this request to the Malaysian local distributor in Malaysia. So thanks for your answer anyway.
Sorry, can't help anymore.
We have a question from Silva. Do you always need imaging before using shockwave therapy? If not, when do you refer for imaging, and when can you do shockwave therapy without any scan?
So this is a really good question. When it comes to NICE prefer a confirmed diagnosis. I know that much. It's preferred. It's not, it's not kind of record. It's not a necessity, but it is preferred. So from that perspective, it just because then the guidelines are saying that. But then from a clinical diagnosis, if you're comfortable that your clinical diagnosis is enough, you can treat. There's no problems with it. We know that shockwave is safe and effective. It's been proven. It's just if your clinical diagnosis is concerned about a potential interstitial tear, or if it's concerned about a calcific density that is been there for a long period of time and is quite large, that it's just not going to respond to shockwave, or that we're not going to get full absorption of that calcium, then I wouldn't really put kind of you might want to query then, do we want to image a little bit. But again, that comes down to your clinical judgment. Your clinical diagnosis is enough to start and commence shockwave. it depends on your precaution levels, and if there's anything that goes on with you and any alarm bells ring in and start going, oh, do you know what? I'm not sure if there is a tear here, because you've just got to be careful, and they can aggravate sometimes. Equally, when there's little interstitial tears within the kind of the lateral epicondyle, sometimes they just take longer to heal. It doesn't make it more susceptible unless there's a kind of a partial thickness tear, or if it's a significant partial thickness tear. So it doesn't make it, we know, like I said, the energies are safe within that parameter that we can use and we can apply. But just if your clinical suspicion is leading you down a different avenue and you're querying a tear, usually, for example, a hamstring tendinopathy, they tend to be gradual progressive onsets. Whereas if the person was sprinting and they felt a twinge, it's probably been a long-term tendinopathy that has developed into maybe a little interstitial tear. So if your history and your examination is kind of going, oh, maybe we need to then go for imaging just to clarify. But it may not necessarily change your protocol either. So this is the other argument where you've got to weigh up, is this imaging going to change our protocol at all? If it doesn't, you can treat. If it does, then you may want to look at further investigations prior to that.
Okay. I
hope that makes sense.
Yeah, totally. We have a question from our famous Chris Downton, who's asking, is paracetamol okay to take?
Paracetamol,
yeah,
paracetamol is, I would say it's fine from a pain perspective. I tend not to advise anti-inflammatories, as I said. There is some thought process somewhere, I think, that there is some literature suggesting that paracetamol can have an anti-inflammatory effect, but it's certainly not an NSAID. I would be happy to kind of say, you can take some paracetamol, I've got no issues with that. What I wouldn't want to do is I wouldn't necessarily want to reduce your pain prior to the treatment. It's the same as having a local anesthetic. We know that if we put a local anesthetic and then do shockwave therapy to reduce down the pain for the patient, it actually inhibits that neurogenic response that we want. So I would try and reduce the pain certainly during the first 20. I would try and reduce your paracetamol intake prior to and during the first 24 hours. But if they're struggling throughout the week, we've got no problem with trying to get some pain response then. But I would definitely try and limit that within the 24-hour period of shockwave therapy and prior to, just because of the kind of, you don't want to have any neurological effect on the tendon, not that, and pain certainly during the first phases or prior to, because it may interfere with the treatment, if that makes sense.
Yeah, definitely. So it would be the same for people who have a treatment with cortisone, or
so we'll come on to cortisone in a little bit, but corticosteroid or cortisone injections for the lower limb we leave 8 weeks, for the upper limb we leave 6 weeks, predominantly because the lower limb is weight bearing. Upper limb obviously isn't unless you're doing handstands, but realistically we would leave it 6 weeks before we commence shockwave if they've had a injection. 6 to 8 weeks.
Okay, perfect. Thanks. Maybe we do an additional one before doing this short break. Cool. We have Evan and Nila asking if shockwave therapy effective for treatment on a frozen shoulder or adhesive capsulitis?
Yes.
And how many sessions would be recommended?
It's really, if you could wait until the end of the presentation, I actually have a case study on that with images. I can tell you now, just in case you can't wait, but it's very, very effective, and we can see significant changes within 3 weeks. It does very much depend on the phase of the frozen shoulder, but if it's very much in the frozen phase, we can speed that process up. So within 3 weeks, you can see significant differences in pain reduction, in movement, mobility. So very, very effective for frozen shoulder, and that is backed up by research as well. So it's not just anecdotal, there is evidence to show this. Very, very effective. 3,000 impulses, that's all it kind of takes. And very, very good. Now, sometimes, occasionally, you can, again, combine that with a corticosteroid injection and or hydrodistension. Again, you just have to leave it that 6-week period between steroid and shockwave. But if you're doing shockwave, they can have the injection, the next day, kind of thing, after the third. But yeah, it's only if you have the injection prior to shockwave therapy do we need to wait. You don't need to wait for the injection if you've had shockwave. But yeah, very, very effective. And if you can stick around, it would be great to kind of see your your opinion and your viewpoint on the images that I've got to show.
You will show us anyway a treatment on shoulder later on. So let's have a short break and let's come back at 11:15. Yeah. Let's go to coffee and
10, oh yeah, 10:15, so 5 minutes for us, yeah.
Oh, 10:15, yeah, 10:15, sorry. That's
okay.
Yeah.
We're ahead. 5 minutes, that's no problem at all.
Okay, perfect. See you in a while. We have lots of questions concerning indications, but maybe we'll go through them during the practical session. What do you think?
Yeah, I'm happy with that.
Yeah, lots of passion around the DolorClast. That's good.
I did just see a question regarding sesamoiditis as well. There has been some case studies there. If anybody is interested, there has been some case studies regarding that. It's not a great deal of literature, but case studies and just using quite high energies. It's anecdotal, but there is some, you can use it. And osteonecrosis as well. There's been one case study of that actually. In 2017. There's 2000 impulses, 5 hertz, 1.2 to 1.8 bar, according to patient tolerance. Total of 8 sessions were delivered. So yeah, osteonecrosis of the sesamoid. There's a tennis player as well. So that one is quite an interesting one. It's 2017 by Dawn Thompson et al. And it's in, I think it's in BMJ as well, so it's British Medicine Journal. So it's a good paper for anyone who's looking at sesamoid stuff, which I think has been mentioned.
Yeah. Lots of questions. We'll come back to the practical because we have lots of questions on indications. Yeah. I'm just checking. Well, we have also questions concerning combination of therapies.
I just saw that, particularly with taping. So Mako asked about taping. I definitely not. I think that realistically that taping is going to provide a barrier, particularly when it comes to the cavitation, etc. What I would do is tape after if you were going to do it. You need a direct contact onto the skin.
Mm-hmm. Okay, thank you.
So if you can imagine, we already have a barrier in the skin. If you provide tape as another barrier, we're going to lose more energy as it goes through that tape because that isn't water content. So you're going to lose more energy there. So it will definitely affect your outcomes. So I would realistically, if you're going to do it, shockwave, tape over, take it off, shockwave, tape over. If you are going to apply it.
I think we had also the same recommendation from Tina Mayo in Australia, is combining taping with a shockwave therapy.
Yeah, you're gonna lose a lot of energy there. It's just not going to penetrate through. but it will. But it's just going to be more of a vibration rather than the actual energy. It's going to lose a lot of energy.
We have a question from Ulao saying, is it really effective for a patient if shockwave therapy is given once a week?
Yes. Yeah, absolutely. That's the guidelines. Yeah, that's what we kind of do in the UK. That's what the NICE guidelines recommend, is 1 session a week for 3 weeks. We give a 6-week review, and then we continue again for another 3 if required. Now, with hamstring, the actual research is suggesting once a week for 4 weeks, and that's what I do. And it is actually, like, I'm going on record and saying this, I've never failed to get a proximal hamstring tendinopathy return into sport. So, or return into the same level of performance. So, like, I would swear by doing hamstring tendinopathy and proximal hamstring tendinopathy once a week for 4 weeks. That is the kind of where I want to go with that. The others you can do 3. You can maybe do 4 if you wanted, but once a week is where we look at in terms of effectivity. And you can do it more. I know, certainly with muscle injuries, there's evidence to say that we want to do that daily. A combination with other treatments as well, but you can certainly do shockwave daily with acute muscle injuries. It's what we kind of look at now in kind of Bundesliga. They tend to use it regularly through there, and the evidence is actually used in Bundesliga 1 and 2. So there's 20 case studies that we can look at with that, and that's actually one of the slides that I've got in what works. So, yeah. But yeah, for your tendinopathy, once a week is good. That's what I do in clinic.
I tried it as well myself, and once a week, 2 treatments were effective for a patella tendinopathy. So that's really effective. Yeah.
From a
everyone can benefit from it.
Yeah, from a maintenance perspective as well. We actually have an elite athlete in at the moment, a professional rugby player, and we manage his as he is symptomatic. So we did the once a week for 3 weeks to get his symptoms under control. As he starts to get a spike in his training and a spike in his load, he then comes in and we have 1 session and he returns when that pain sort of increases. So yeah, for the initial phases to get it under control, absolutely. And then you can work around it then to pain tolerance and maintenance.
Definitely. And we have a question. I'm trying to select the questions not relating to indications because we will come back to them later. But we have a question about rest. How many rest days between shockwave therapy, and what happens if the rest days are too close?
Right. So
Judith. Yeah.
So if we're looking at rest days, is that rest days in between sessions? So so we would leave 7 days in between every session, but I tend to advise the patient to have 24 hours off following shockwave from high strenuous activities. And the reason being, as we said, because we make that tendon, we hyperstimulate that tendon, it makes it a little bit numb, means we can load it more, which makes it more susceptible. So that's the reason why we give 24 hours off after the treatment. But that's it. With regards to rest days, I tend to monitor the load quite a lot, so I wouldn't have them doing high, particularly with the Achilles. I wouldn't be doing plyometric load towards the end stages more than 3 times a week, because we need to get that tolerance back up. I would certainly reduce plyometric load in the initial phases, just get the pain under control, and then go to pain tolerance and increase again. But yeah, just a 24-hour period after the shockwave is ample from high strenuous activities, but a week in between sessions if that's what you meant as well.
Okay, thank you.
Should we? Do you want me to move on to the what works section, or are you happy to answer a few more questions?
Maybe we'll answer them later.
Okay.
Let's go ahead with your presentation.
Cool. Okay. So here we go. So we go on to the indications. Okay. So this is when is shockwave appropriate, really, and recognized condition that is known to be responsive to shockwave therapy. As I said earlier, NICE state that a confirmed diagnostic via MRI or ultrasound is preferred, but it's not essential. Typically, this is a little bit of a change now when it comes to the GDT, but typically with shockwave alone, we get better outcomes with the treatment being longer, or the pathology being present for longer than 3 months or longer than 6 months. So when it's in that chronic phase, if the patient has failed conservative management, then shockwave is appropriate. If surgery or more other invasive procedures are the only remaining options, again, we can consider it appropriate, but only when there are no known contraindications to care. So if surgery is available, for example, they want the surgical intervention, however, there is a contraindication, the patient has been recommended surgical intervention, and they don't want to go down that road, shockwave may be appropriate. However, if there's a contraindication in place, it's not appropriate for obvious reasons. So the contraindications override the indications, which just is common sense. So the list of kind of indications that I use typically in clinic, and I don't deviate away from massively. However, again, we can trial that certainly in different approved versus experimental lists. But I would typically use lateral epicondylitis or epicondylopathy, depending on your terminology, medial epicondylitis or opathy again, subacromial pain syndrome, calcific tendonitis, greater trochanteric pain, patellar tendinopathy, Osgood-Schlatter's disease. There's a star by this because it's proven safe, but there is also a contraindication based on the demographic of patient that Osgood-Schlatter's occurs in. Medial tibial stress syndrome, Achilles tendinopathy, both mid-portion and insertional, and plantar fasciopathy. So all of those are kind of what you would generally see in practice and make up 90% of your shockwave clientele, no doubt. From a precaution perspective, we need to be cautious if people are on clotting, if they have clotting disorders or on anticoagulant therapies, can lead to bruising or excessive bleeding. If they've had recent steroid injections, as we've already discussed, so if the upper limb, we leave that for 6 weeks, lower limb, we leave that for 8 weeks. If they've had recent NSAID usage, again, it just counteracts the effectiveness of the treatment more than anything. If they've had a joint replacement, so this is key, this isn't a direct contraindication, but you need to be very cautious around joint replacements. And from a contraindication perspective, we should not perform over or for the following. So we shouldn't go over major blood vessels, definitely no over air-filled regions, so lungs, bowel, etc. Growth plates, and this is the why there's a star next to Osgood-Schlatter's, is that there's actually evidence out there to show that it's safe to use over the tibial during that particular demographic, which are going to be young teens, often boys, just because of the sports activities that they perform. But it isn't out of the question to have it in females either. But yeah, you know, it is a normally 12 to 14-year-old really who would kind of develop that as it's going. Obviously, what Osgood-Schlatter's is a traction spur on the tibial tuberosity. It creates this inflammatory response in apophysitis, and that we would say that obviously it's a contraindication in any other open growth plate except for that one. The argument could be made for, well, if we can do it for that, why can't we do it for the others? The reason being is that the literature hasn't had the go-ahead. There is no evidence to say that it's safe to do so, and that's why. Whereas, you know, is there a difference between growth plates other than location? Maybe, we don't know. You know, will it respond differently? I think ethics is probably what's holding that research back, just in case, because we are looking at young teens, particularly with like Sever's disease, for example. We obviously don't do over bone tumours and metastases. We try not to use it during pregnancy. Now, again, this is probably a litigation contraindication rather than a direct response contraindication. The reason being, if you carry out shockwave on someone's plantar fascia and they're pregnant and they have a miscarriage, the patient could potentially look at any potential cause for that. And if they said, oh, I had shockwave, it is a contraindication. It's listed as a contraindication. So the blame lies on you as from a legal standpoint. So that's why it's a contraindication. I don't think there's any evidence, and again, this comes down to ethical studies. I don't think there's any evidence to say that it's detrimental. Obviously, over the fetus, it would be, but away from it, I doubt it. But it is a contraindication for that reason. So try and obviously avoid pregnancy. Open wounds, and again, what we mean by this is if there's a cut over the patella, try not to do it over that. The infection risks, etc. However, there's a star and it's in bold because we can actually we can use shockwave therapy for delayed wound healing, certainly with diabetic ulcerations, etc. Ian Vasey down in Turkey, he's done a clinic in this with diabetic wound healing, and they've had very, very good outcomes and good responses with that. So it's a contraindication if we're not doing it for that purpose. So if there's a cut on, a big wound on the shoulder, but we're querying a calcific tendinopathy, we wouldn't do it over that area. But if you're wanting to maybe do it for, it's in the sterile control clinical environment, normally in hospitals, we would do it for open wound delayed healing. So it's a very difficult and different setting and clinical setting to what I would be in day to day. This is the PEDRA database that we were talking about. So this is currently, there's 45 studies on it, and 30 of which are radial shockwave. They're all radial shockwave therapy, but of the 45, 30 are actually using the Swiss DolorClast. 80% of the DolorClast research had positive outcomes, and really in the 20% that didn't, you could question the methods. So, they weren't potentially using enough energies, or the patient selection was incorrect. But 80% will have very good outcomes based on the evidence that we receive from the PEDRA database at the moment. As you can see in here, you have a selection of research, majority of which is the lateral epicondyle and plantar fascia. Again, as we said, the early studies were looking at plantar fasciopathy and heel spurs, and lateral epicondylopathy, and this is why the majority of the interest has been there. So yeah, really, if you have a referral or a reference list that you want to go to for conditions, PEDRA this is there, and the majority of them are actually done using a DolorClast machine. So again, leading the way with the evidence. Okay, so this is a new slide, and this is the first time that I've kind of presented this. And one of the things that you want to look out for within the literature is the presence of Nicola Mafuli and Christoph Schmitz. Both of these guys are pretty much shockwave gods, really, and they've been certainly asked to kind of co-write and be a part of a numerous abundance of literature on shockwave therapy. So if you see a study with their names attached, it's a good quality study. This was looking at the return to play after treating acute muscle injuries in elite football with multimodal therapy approach that includes specific protocol of almost daily radial shockwave therapy. Now, again, worth noting the word multimodal is that it was, they did use cryotherapy, they did use rehab. There's other manual therapy techniques as well that we used alongside the shockwave, but shockwave was used and was a vital part of this on a daily basis. So they looked at this is the muscle injury classification that we have. I mean, this is really important that we all speak the same language from a muscle class, so we know what muscle injury we are particularly dealing with. It's really important because there is numerous muscle injury classifications out there. We have BAMIC here in the UK, which is British Athletics. We have, this I think is the Berlin one. This is the Berlin classification. We have the Barcelona classification. The Barcelona classification has over 216 different classifications for muscle injuries. So this is really important. When we're talking about a specific muscle injury, we clarify the classification methods that we have used. So this is the classification methods that they used, and this was the same classification methods that they used during Ekstrand et al.'s study in 2013. So if anyone knows anything about kind of Ekstrand studies, he was using this method, and this was in 2013. Xstrand give an average time frame of recovery from each of these different classification of muscle injuries. So we know that these typically will respond on average to a set time based on the severity of the injury that you see, and this is all based on MRI findings. So the methods that they used was 6,000 to 12,000 impulses at a pressure of 1 bar to 3.4 bar, and this is all very much dependent on your patient tolerance. They also use the frequency of 20 hertz consistently across the board, and they use the 36mm applicator. And this was because in 2020 we hadn't launched our radial shockwaves at that point. So this research was prior to, it was pre-radial shockwave machine, but they were using the Master Touch or the Smart 20. That's the one thing that you want to know, is that 20 of the injuries were reported, 19 of which were treated with the radial devices, and they were all EMS and Swiss DolorClast devices. The other one was used with Focus, which again was the PiezoClast, which was a DolorClast unit. Now, what the results showed was a reduction in layoff times. Type 1 injury, I think, I can't actually see because my screen is covered, but it's around about 56% or 58% type 1A injuries. There was a complete reduction in from time lost and return to play. You could speed up that time by 58%. With type 2B injuries, that is a muscle-related neuromuscular dysfunction, we had 55% reduction in layoff time. And type 3A, which is a minor or partial tear, less than 5mm, and it was intrafascicular, so within that muscle, we had a layoff of an average of 21% less. So we had a 21% faster time return on a 3A classification of muscle injury, and that is a severe muscle injury, which is phenomenal. So we could get these players, these athletes who are recovering from quite detrimental and a quite time-consuming injury back to their sport, competing at a high level at 21% quicker with quite a severe muscle injury. When we look at it as well, it's worth noting that these were all footballers. They were all in the Bundesliga, that was Bundesliga 1 and 2, not in Bundesliga, the main league. So that was the first and second divisions below that. But still, the reason why we've only got data on these three kind of sections or subsections of classification is because we didn't see any difference. These are the only type of 20 injuries that were recorded during that time frame and treated. So yeah, for you to get fatigue, a 56% ease in your layoff times due to fatigue onset of fatigue-induced muscle disorders, neuromuscular-related muscle disorders, and also a physical injury is pretty good. So this is new evidence that was out last year, again with very high quality evidence and a good paper if you want to read that. So we'll go on to onto foot pain and plantar fascia. I know there's a few podiatrists and pods out there today. So this is one of the early studies, and again, Christoph Schmitz was involved with this, and Ibrahim et al. They were showing that results basically of the present study suggest that the use of radial shockwave therapy in presence with chronic plantar fascia is effective and safe, and leading to significant long-term reduction in pain without any adverse effects. The methods that they use is 8 hertz, 2,000 impulses, a 3.5 bar. The keynote and the side note to this for this subsection, or this patient base in this demographic, was actually we should use shockwave therapy as a primary source and a primary treatment, certainly before corticosteroids, because of the risk of rupture that is associated. So it's really quite an interesting one, and this isn't a new study. I think this was 2011, so this is a 9-year-old study yet we still sometimes in some, certainly within the NHS in the UK, we will still prefer an injection, even though 9 years ago we were trying to say that shockwave should be used as a primary source. So yeah, we do have that evidence there now. Again, I put this in just to highlight the importance of exercising. I know that one of the questions that was asked during the break is, can we use shockwave therapy alongside exercise? And it's absolutely encouraged. That's what we want. We want you to be rehabbing the patients alongside your shockwave therapy, your laser, whatever it is. We want you to be doing your rehab alongside that. This was a study in 2009 by Romp et al. And again, Christoph Schmitz, Nicola Mafuli, they're both involved with this. It's a very high quality study. And they were basically saying that they did a really basic stretch. They did a very, very basic stretch. What we sometimes find, certainly in private practice, and even certainly within the NHS or kind of government supported care, is that people are reluctant to maybe do some exercise and to do some rehab. Now, this is an exercise or a stretch where we had a patient sit down, they bent their big toe into maximal flexion and placed their ankle into dorsiflexion, stretching that plantar fascia. We asked them to hold that for 10 seconds and repeat 10 times a day. By doing that more simple stretch, it actually increased the efficiency of shockwave therapy. It increased the outcomes. So if we have a patient who is unwilling to sit there for 100 seconds and stretch their plantar fascia, you maybe want to question whether or not they're happy and want to help themselves as well. But it's a simple exercise. I tend to go down a little bit more of a specific loading management, but this is evidence to say that a really basic stretching program adds to the outcome of your shockwave therapy. So from ankle, we will specifically look at the Achilles. There was a few key points from this study that looked at saying, well, mid-portion Achilles tendinopathy tends to respond better if we wait post 6 months. But there's no reason why we can't do it at 3 months. We just know that this study was suggesting that better outcomes are achieved if the pathology is 6 months old at the start of shockwave. But also, best outcomes are achieved with participants who partake in both eccentric loading as well as shockwave therapy. And this is really interesting. Again, what we know from eccentric loading and certainly from load research is it doesn't matter how you load the tendon. Are eccentric loading better than slow and heavy loading? Probably there's no evidence to suggest there's any difference in outcomes. The only reason that they've specified eccentric loading was that this is what this cohort did. There is no significant difference in the outcomes of the type of loading, the load management techniques that you use, whether or not that's slow and heavy, whether or not it's eccentric loading specific. You will still get good outcomes if you combine exercise with shockwave therapy. This is a big study looking at mid-portion Achilles tendinopathy again, and what they basically looked at, this was a huge systematic review. They looked at an abundance of research, and they found that the recommendations for mid-portion was 2,000 impulses, 8 hertz at 3 bar. That was our aim. That's where we were kind of looking at within this literature and within this study. Now, when it comes to insertional tendinopathy, it's a little bit different. Again, Nicola Mafuli involved here and Romp involved. It's the same people who are involved with the plantar fascia studies. And they basically concluded that eccentric loading, as applied in the present study, showed inferior results to low energy shockwave therapy as applied in patients with chronic recalcitrant tendinopathy of the insertional Achilles at 4 months of follow-up. So what we were saying by this is that shockwave therapy was better than eccentric loading alone. However, I think that the eccentric load program again that was carried out was a little bit questionable. However, we combine them anyway. We combine shockwave with our loading protocols, and that's where we're going to get the better outcomes. So it's all well and good comparing them as an individual entity, one versus the other, but realistically, we want one versus the other versus a combined, and we can see which gets the best outcomes. That is where you're going to get your best outcomes. That's where you're going to get your patients better, is if you manage their load and combine that with the shockwave. knee pain. Like I said earlier, we're actually using this currently with a professional rugby player. I work with a professional rugby club in a professional region in Wales, and it's a really difficult one to manage. Like I said, it's really difficult to manage with athletes during the season. They're going to kind of expose themselves to increase in load. They're going to expose themselves to rest periods. They're going to expose themselves to playing. They have to play. It's their job. That's what they're going to be doing. But this study was basically looking at refractory patellar tendinopathy in failed conservative treatment, and when should we carry out shockwave or when should we carry out an arthroscopy. And it actually highlighted the importance of an MRI. They say that if a patient has kind of fat pad involvement within within the patellar tendon, they don't get as good outcomes with shockwave therapy, and in which case arthroscopic debridement is probably the best view. However, like we said in the indications, as long as there's no contraindications, shockwave is an appropriate option for it. It's just that they're comparing the outcomes, and they were saying arthroscopic is a view if the fat pad is inflamed or if there's any effusion within it, and that would be highlighted by an MRI. But for the most part, we get really good outcomes with patellar tendinopathy as long as we manage to work with the some strength and conditioning and work on some rehab alongside. Isometric loading is very, very effective for pain reduction. So we can combine both of those. Isometric loading, get your methods and your load. For this player in particular, we're doing 2000 impulses, 12 hertz to his tolerance. We start quite low and get a ramp up, and he does very, very well with that. Like I said, we initially did once a week for 3 weeks, and we got better, pain reduced, and then we brought him back to basically when he starts to feel that he's getting a little bit symptomatic, and we carry out a shockwave session then. But that's it. So looking at the research, a control group, I think this control group was either placebo or conservative care, non-shockwave conservative care. And when we compared the two, we were actually looking at basically the results speak for themselves. The excellent outcomes in 13 out of 30 participants, good outcomes in 14 of 30 participants, and fair outcomes in 3 out of the 30 participants. Now, interestingly, 13 of the 30 had a reoccurrence in symptoms. And again, as I said, this isn't uncommon with patellar tendinopathy, particularly in athletes. What I will say about patellar tendinopathy, you don't get sedentary people with patellar tendinopathy. This is a jumper's knee. This is somebody who's doing a lot of repetitive load. It's someone who's doing a lot of jumping. So recurrence is quite common. But compared to the control group in this, 50% of people had a reoccurrence in the control group. Only 13% had reoccurrence in the shockwave group. So there's a reduction in the long-term outcomes and less reoccurrence. And also the control group had less significant or less, it was 0% having excellent outcomes and 50% having good outcomes. So the shockwave was superior to a control management in this study in both long-term, short-term, and reoccurrence. And this is an Osgood Schlatters study, and this is the one that we were talking about. This was a German study, and I did have to Google translate it to get the results, so there may be a little bit of loss in translation somewhere. But the methods they use, 2.5 bar, 5 hertz at 1500 to 2000 impulses, and it was roughly 3 to 7 sessions, which is very, very big. I have used shockwave therapy, and I haven't changed the protocols from the NICE guidelines. I've used 3 sessions, review in 6 weeks, and 3 if needed. I have tried to go to the patient tolerance, but I will use a lower frequency for it. So I will go in the 5 to 8 bar at 1500. I think that it's cruel to go above more. It's a little bit painful, that frequency. So, and that pressures. But yeah, we've had very good outcomes with Osgood Schlatters, in fact. So, this is the method that the research is suggesting. It's shown to be safe, it's shown to be effective. The problem with this study is that there's no control group. So we have no idea to say if it was superior to control. But again, the key factor is that we know it's safe. That is the big thing, is that when we look at the contraindications, we see open growth plates as a contraindication. There has been research carried out. None of these people, none of these children had adverse effects, none of them had adverse outcomes, and they were all having, they all had pain reduction. So very good, but as I said, no control group. Anecdotally, I've done it on a handful of patients, and they've all responded really well. It's very good. From the hip, we typically will look at greater trochanteric pain. And this is a really, really good study where they combined home training, local corticosteroid injections, or radial shockwave for greater trochanteric pain. The problem that we have with greater trochanteric pain syndrome is that it's broad. It's a very broad diagnosis. Is it a bursa? Is it a partial thickness tear? Is it a tendinopathy? Now, I tend to MRI these prior to commencing treatment. Only reason is I think that they respond better to tendinopathy than they do to bursal effusion, etc. Now, interestingly, we can't actually confirm whether or not bursa is a pain generator. We can't tell if the tendon's a pain generator. And this is why we've umbrella termed this diagnosis now as greater trochanter pain syndrome, or greater trochanteric pain syndrome. From this study, however, what we were showing is that greater trochanteric pain, both corticosteroid injection and home training, was significantly less successful than shockwave therapy at a 4-month follow-up. And corticosteroid injection was significantly less effective than home training and shockwave therapy at a 15-month follow-up. So we continue to inject these everywhere. We continue to inject them blind, we continue to do guided, but we know that home exercise, home training, and shockwave therapy is superior to corticosteroid, both in the long term and in the short term in 4 months. So if we are still injecting them, we potentially want to look at another avenue, because it's not responding, it's not giving your patients long-term relief. We really want to start looking at other avenues, rehab, combining that with shockwave. That's where we're going to get the long-term results. That's, you know, again, and that's something that I would echo and completely ditto anecdotally. I don't inject. I'm not allowed to inject. I'm not as a chiropractor, but I wouldn't be referring my patients for these actively as a first line of treatment for an injection. This is, yeah, so here we go. This is where we combine them. So as we said, we've looked at them in isolation, but this is where we combine rehab with shockwave. And the protocol was once a week for 3 weeks, and the home exercise program consisted of lumbar mobs. They're looking at strengthening of the hip and the glutes. And again, there was really good outcomes. And the outcomes were showing at, let me just see if because again, my screen is covering us. But at outcome measures, non-arthroscopic hip scores, so these were questionnaires, there was significant increases, or certainly significant responses in Oxford hip scores, non-arthritic hip scores at 6 weeks, 3 months, and 6 months. And also what was really interesting is that hospital anxiety depression scales were also significantly reduced across the board at 6 weeks and 3 months and 6 months. So just because we were able to get these patients in out of pain, we were able to probably increase their activity levels. This led to actually a reduction in their depression scales. So not saying that shockwave reduces depression, but it actually increases the life, you know, your quality of life in these patients, because obviously this is a very, very good research, because it looked at more than just pain. It looked at the functionality, and it also looked at the, you know, the holistic approach, as it were. I think it also significantly increased the activity levels, if I'm right in saying. I can't actually see the data. There it is. Let me move that out of the way. Yes, it did. So we, at 6 months, they were actually carrying out statistically different and kind of improvement in the vigorous levels of activity. And walking in minutes per week increased statistically based on the baseline scores. So at 6 months, people were more active. carrying out more vigorous exercise, and were getting reduced scores in their disability questionnaires, and the depression scores were lowered as well. It's a very, very good study, this one. Oh, there we go. Okay. So shoulder pain. This is really, really good one. This is important when it comes to shoulder pain, really. The efficiency of shockwave therapy on non-calcified shoulder tendinosis, and what this study showed was that it demonstrates a significant increase in outcomes with those patients who have a calcific tendinopathy or tendinosis. So if your patient has a calcific tendinopathy, you get better outcomes. However, other therapy should be considered if non-calcified shoulder tendinosis or tendinopathy. So that's what the literature is saying, that we get better outcomes if there is a calcific density within the tendon. Now, anecdotally, however, we do get good outcomes with subacromial pain. If it's a true tendinopathy, you can get good outcomes. However, if you're looking at more bursa, partial thickness tears, not so much. It's all well and good knowing when to do it, but it's also knowing when to expect less significant outcomes. And this is what this study looked at, as the prognostic factors, so your outcome, your likelihood of outcomes with the calcific densities. So this was based on the Gartner and Heyer classification of tendinosis and calcific tendinitis. So type 1, type 2, type 3 as shown, and these tend to be in the formative phases and the reabsorption phases of that calcific tendinopathy. And what we know is that a type 1 calcification, which is a well-circumscribed and dense calcification that has been present within the tendon longer than 11 months and is larger than 1.5 centimeters, they were statistically less likely to show increase of resorption or reabsorption. But that doesn't mean that we can't increase the function and reduce the pain with those patients with shockwave therapy. So the reason why we mention this is don't put emphasis on the patient's calcium within the tendon, because if it is been there for a long period of time, and it's quite a large calcific density, and it's certainly type 1 in that formative phase, it's unlikely to fully reabsorb. So don't put emphasis on that as a clinician, because it's unlikely to see a statistical difference in it. However, that doesn't mean that we can't reduce their pain and improve their function with rehab and shockwave. Okay, so although the tendon, the calcium doesn't reabsorb, it doesn't mean that we can't change and improve their function in general. So here's the case studies that I was talking about. And this is a 26-year-old male. He's an ex-bodybuilder. He's lost a lot of bulk since. You'll probably see that in the images. He subjected himself to years of abuse in the gym, heavy loading, very heavy bench pressing. And this resulted in significant capsular tightness and pain basically on moving. There's a little side note to this. Every year his mother buys him a back scratcher for Christmas. He literally is unable to reach his back to scratch it. Ultrasound scan shows no tears or capsular thickening observed at the rotator cuff interval. So this is how he presented initially. That was his left shoulder, that was his right shoulder. And as you can see, there's a significant reduction in range of motion on the right compared to the left. Now, this was immediately following the first session, an increase in that left range and a significant increase in that right. So we are now pretty equal at that point. After 3 sessions, that was his left shoulder. This was his right. His right was still a little bit restricted, but that left shoulder is now a complete return to normal function. So if we go back, this is how he was. That is a massive change. And those of you that were asking about frozen shoulder, this was a lady that presented to the clinic with that being her maximum combination range of extension and internal rotation. After 3 sessions, which is impressive. It's not full, it's far from full, but we were able to get something that is a natural history of 2 years to get that much range increase in three weeks. And the other thing that I didn't take note of was that the big one is functionality with frozen shoulders. People often complain that they can't wash their hair. This individual was washing their hair pain-free, which is a massive change in her lifestyle for her. So, you know, again, quality of life beyond pain was improved for this patient. And I wish I took a photo of that one, but I didn't. But that is within 3 weeks of something that should take 2 years as a natural history. So just bear that in mind as well. So that's it from the theory side, which is kind of, you know, happy days. And we can now go on to the practical, but I'm also very happy to answer some questions that have been asked. Feel free, you can follow me on Facebook, you can follow me on Twitter. Those are my handles, or kind of @. I don't know what the social media term for it is. So feel free to reach out via those if you need to.
Thank you, Dan, for the recap on this on clinical evidence with supporting all these pathologies that can be treated with shockwave therapy. We have lots of questions, concerning frozen shoulder. That's done. So for frozen shoulder, you did 3 sessions for this lady who could not wash her hair.
Yes. Yeah.
Okay, 3 sessions.
Once a week for 3 weeks. And those were the outcomes with those. We use quite low frequencies on that, so it was around about 8 hertz going to patient tolerance, and then 1,000 impulses in specific locations, which is based on the literature, which I'll run through in the practical. But yeah, it was the 3 locations of the kind of crackohumeral ligament, the pec tendon, and the posterior capsule.
Okay, thank you. We have lots of questions. Can we do shockwave therapy at the back of the neck? This is a tricky one.
Yeah, you can. You know, I would personally use a larger applicator head for that and work through the traps. You know, again, it's, if you think of it, I certainly wouldn't be using the 15mm head. We've got a lot of penetration and depth there. Again, it's very close to the brain, so that's one of the risk of the side effects there. So you can use it, but you have to be careful with your techniques. The other thing that you have to take into consideration is your lung-filled regions, which are the air-filled regions with your lungs underneath, and potential risk of pneumothorax. So just be aware of those. But it is doable with a 36mm, and you can run through the traps, which is quite nice. But you want to limit the penetration, and you certainly want to limit the risks. I tend not to do it, if I'm honest. As a chiropractor, I do all my manual therapy up there. But you know, it is doable, and there are ways to do it.
Okay, thank you. We have a question from Carola asking, can you tell more about trigger finger treatment, local in the hand or on the muscle belly?
Interesting. So I tend to go at the trigger. The reason being they're pulleys. The trigger finger tends to be a pulley issue, as opposed to kind of you get. Yeah, I work at the location, like Dupuytren's contractures at the nodule, so that they tend to be a pulley issue with the trigger finger, as opposed to a nodule with it, which is like a Dupuytren's contracture and plantar fibroma are very similar in that sense. From a trigger finger, I work at the trigger, I work at the pulley. So I tend to go quite high frequencies because it is quite uncomfortable. I've got a trigger thumb that I'm treating at the moment. Significant reduction in pain, massive improvement in grip strength. She isn't out of pain, but her functionality is increased and her pain has significantly reduced. So I always work at the pulley. It's only the one pulley, I believe, that we typically see it in. But yeah, so I would work on that site at the pulley and at that region. I tend not to do a great deal up into the musculature, but there's no reason why you can't. It's not going to do you any harm. And you can probably even actually work into the, if it is kind of the smaller muscles of the hand, you could probably work a little bit into there as well. Yeah, there's no reason why you can't.
Perfect, thank you. Another question from Samantha Peters. After corticosteroid injections into joints, either elbow or shoulder, how long do we wait to resume shockwave therapy?
So 6 weeks for the upper limb, 8 weeks for the lower limb.
Crystal clear. Thank you. A question from Warren. Hi, Warren. What would be an average recovery time for plantar fasciitis? How many sessions and weeks?
So it's really interesting. Plantar fasciopathy or plantar fasciitis, they can be quite stubborn. Some of them can be really stubborn, and they can take a while. Let's not forget that these are chronic conditions, and the full response, we are expecting kind of 12 months recovery. What we will see is that we will get significant improvements within that first 3 weeks. Usually in about 80% of patients, they will respond within that first 3 weeks. If there's no response within that first 3 weeks, I tend to kind of go, well, is it worth doing another 3 if we haven't had any improvement? Usually by that third session, I'd expect maybe a 20 to 40% improvement. And then maybe by the review stage, I would like around about a 70% improvement by that review phase. Now, when we finished out the 6 sessions, if you do that, and you've finished out your 6 sessions, I would then do a 12-week review. So if you take all of that into consideration, we've got 18 weeks and 6 weeks. So with 24 weeks really is the maximum time frame that I would want to be reviewing people. So that, that is a significant time frame. But as I said, that's tend to what we see is you can get really good outcomes, and some people respond miraculously within 3 sessions and there's no pain, nothing at all. But the stubborn ones, they can last that little bit longer.
So it depends as well on the patient.
Really, yeah. There's no cookbook with it. They don't know. But for me, I tend to go. That's what I would expect. If people do better, great. If they do worse, then unfortunately, I tend not to recommend for more sessions. If there's no change within that 3 sessions, I tend not to recommend any more. Just I don't want them to waste their money, really.
Okay, thank you.
No problem.
Question from Core. Can shockwave be carried out near fracture region? Is it during the callus formation?
Yes, yeah, absolutely. Certainly during non-unions, there's a lot of research on non-union fractures in the scaphoid, for example. So yeah, you can increase the healing responses. Johnny has done. He shows some research on this, and it does really increase the callus formation in the long bones, particularly. Johnny also shows some work on kind of amputee pain, which is really interesting study. There was the patient was amputated of the femur, I think it was, and he was getting a lot of nerve pain basically at the stump. Yeah, he was getting a lot of stump pain. And shockwave was carried out. There was no change to the function. There was absolutely no change to the structural entities within the bone. However, there was a zero kind of no pain was reported following shockwave therapy. So it can work on stumps for neurogenic pain a lot of the time, and it can also work on fracture healing and delayed non-union. So yeah, it is doable. I will say I don't do a great deal of that. I don't see enough of them to do that. But the research is there.
Okay, thank you. We have a question from Regine asking, well, this is a contraindication, this one. Is it safe to do also on the thoracic area?
So, yeah, not for me. I don't. Again, it's because of the lungs. So not really. You just gotta be very careful. What we know is that shockwave doesn't penetrate bone. It can't penetrate bone. Now, unless you're comfortable that you're on a rib, I certainly wouldn't really be recommending it. You're dicing a little bit there. You have your lung directly underneath them. Over the scapular area, no problem at all, because we know it's not going to penetrate to the scapula. But over the thoracics, I'd be very wary. I don't do it personally.
Not recommended. On kidneys, for example, we had also this question.
Same deep down underneath. Yeah, absolutely.
Yeah.
And abdomen. So we do have to be a little bit careful with the low back as well. So.
Yeah, true. Another question from Glenda. How many shots does each bullet produce before the cartridge needs replacing?
Oh, it's interesting. This is, this is really interesting.
Not sure if this particular shockwave therapy uses replaceable bullet cartridges.
So
probably
she
has a naval blue handpiece, Glenda.
This is a new one. This is the new cartridge. Very similar. In here is a little bullet, and now they're guaranteed for, I think, 1.2 million MC. Correct me if I'm wrong. I think they're guaranteed for 1.2, maybe 1.5 million impulses. Chris is a little bit more generous with that, certainly in the UK. Chris kind of recommends you keep going until it stops, is the answer. It doesn't lose efficiency, it doesn't lose performance, it doesn't lose its capability unless it stops working. So they are guaranteed for, I think, 1.2 or 1.5 million impulses. It may even be a million, but they are up to a million impulses, maybe even more. Chris will be able to definitely kind of specifically tell you the exact number. But you then change them. It's actually quite a simple process. I think with the Evo Blue, it's going to be slightly different. What we tend to do is you leave that on when you're changing it with the new DolorClast Blue. Then you change, you can take, if I can, screw that on very tight. So I've just had confirmation, the warranty is up to a million impulses. Thank you, Graham. So that comes off. That comes off. We then have a lock there, and that comes out. And that's as simple as it is to exchange that cartridge. Put it back in, lock that down and rotate. We put the casing back on. If I can, let's go the other way. So the casing goes back on there, and I didn't lock it in. Sorry, my fault. There we go. So that goes in onto there, and then it's as normal. So that's how it works. So you know they exchanged every million really, of warranty for a million, but you can keep on going.
Very easy process to replace the cartridge. Yeah.
Yes.
Thank you for showing us. Yeah.
I think they also have. I'm sure you guys have competitions. Who's the quickest? So it's very much a quick draw competition in Switzerland. Who can do it the quickest? I think Chris is down to something like 4 seconds, maybe. But yeah, so. I think.
I remember. Yeah.
So yeah, there's often sporting events around changing cartridge. But yeah, so they can be done pretty quickly if you need to.
Thank you. We have a question from Ernest. Can shockwave therapy be combined with regular exercises? Is it advisable to continue with exercises, or should the patient rest for some time?
Yeah, 100%. We've just gone through that, haven't we? So yeah, definitely. I think that from a rehab perspective, we want people to be rehabbing. The only thing I would say to that as a little adjunct is that we want to give them a 24-hour rest period after the shockwave, just because of the risk of rupture. Mm-hmm. But otherwise, fine. Yeah, good.
This question can be answered for the next webinar on GDT, but I don't talk too much about this.
Yeah, I've actually. Yeah, I was going to bring mystery. It in. Yeah, exactly. I was going to bring it in as a little tease, but I thought no.
We have a question from Obok Leong. Does this work for bone spurs?
So this is interesting. If we're particularly looking at heel spurs or enthesopathies or traction spurs, it's really interesting because we don't know whether or not the bone spur is symptomatic or not. We don't know if it's relevant. We don't know if it has any clinical significance. Are we treating the spur as a pain generator? Are we treating the surrounding tissue as a pain generator? So for heel spurs, for example, particularly if we're looking at calcific tendinopathies or sort of insertional Achilles tendinopathies, often they are calcified. Doesn't change anything. So yeah, it's very effective for that. Are we treating the calcium? Are we treating the spur? Are we treating the Achilles? What we know is that there's neovascular change around surrounding that calcium, so there is an irritation of the tendon surrounding it. So yeah, absolutely, it works. Do we know if it's specific for spurs? Probably not. But we know that obviously from an imaging perspective, there is corresponding irritation of the tendon as a result of the spur or fascia. So yep, it works really well. We don't want to break it down. We can't provide enough energy to break down the spur. We can't destruct the spur with the energies that we've got. So we're not it's not lithotripsy. We're not trying to break it. We're not trying to fracture it, but we can certainly help with the symptoms and the function around it. In my experience, they tend to, when there is a little bit of calcium in the tendon, they tend to take that a little bit longer. So just be a little bit prepared for that. But equally, you can get some miraculous recoveries as well. So, yeah.
So you would use a small applicator with a.
Yeah, I'm pretty well with them.
Much.
I do go in with a 15.
Okay.
But you can again correspond, obviously, as we said earlier, change your frequencies. Reduce your bar, maybe do analgesic prior. There's plenty of ways that you can work around it because they are quite uncomfortable right on the tendon insertion or fascia insertion.
Okay, thank you. Another question from Louise. In your experience, is it more effective on chronic conditions rather than acute ones?
Yeah, so all the literature is done in chronic except for muscle injuries, which is acute. We are obviously, again, this touches on GDT a little, but we are now looking at combining ways of getting subacute and acute conditions being treated. So I'll leave that for next month, as we've got a full webinar next month, which is probably a little drop there. But we have a full GDT webinar next month, and you will hopefully learn more about the acute and subacute conditions there. But yeah, chronic 100% for shockwave as a sole entity. Chronic works better.
Okay, thanks. We have a question from Ewan. Do you still do a gradual tendon loading program following the shockwave therapy? When did you start this?
Yeah, recommended as soon as they can get patient tolerance or load tolerance, sorry. So the way that we measure load tolerance is based on, it's the kind of a new approach now that we're all looking at, is that we don't want them to stop running. We don't want them to stop doing the activities that they enjoy. What we want them to do is find the tolerance level that they can carry it out, that it isn't detrimental. So we use a tolerance level of 3 out of 10. If they can run at 3 out of 10 for 5 kilometers, for example, if they can do a 5K run, 3 out of 10 pain, and there's no aggravation within that following 24 hours. So if it stays within that 3 out of 10 bracket within 24 hours, they can keep it at that distance. However, if they go for a 5K run and then the next day is starting up into 7 or 8 out of 10, they've done too much in that day. So the same thing occurs with the loading programs. If you want to offload them and strip them back from their running, you can do so. I tend not to, but I work around the strength and the rehab stuff around that 1 or 2 plyometric sessions a week, but it needs to be within their load tolerance, particularly with the Achilles and the plantar fascia. They're nightmares for runners because they just want to run. They only want to run. They don't want to do any conditioning to get them fit to run. They just want to run. But that's why it's actually quite important to get that load tolerance sorted quite early on. If you need to stop them just for a week to get that pain under control by doing some isometrics, by doing some slow and heavy loading, and then gradually progressing up into your plyometrics, fine, absolutely fine. But yeah, it's 100% recommended. Just leave off, don't commence until you've started 24 hours before. Don't commence until you've left 24 hours after the shockwave.
Okay, thank you. We have a question from Taizia asking how often would you treat an Achilles tendinopathy?
Achilles?
Yeah.
Once a week for 3 weeks again, and then review. You can do 4 weeks, but once a week for 3 to 4 weeks, and then review in 6 weeks, and maybe do another 3 if required. Even with a recalcitrant
Achilles tendinopathy?
Yeah, same.
We have a question from Grant asking, according to Professor Jill Cook from Australia, she feels that shockwave is a lazy treatment of a tendinopathy. She feels that the tendon should be loaded. where would this loading be applied according to the shockwave application?
So this is kind of what we've been saying throughout this, is that, you know, shockwave in combination with loading is going to get you the best outcomes. I've done Peter Malliaris's courses when you look at tendinopathy, and it's an adjunct. You know, we can get good results with shockwave alone, we can get good results with loading alone, but if we combine them, we get better outcomes. I agree. It's probably lazy from a patient's perspective because they haven't got to do anything. It puts all the pressure on the practitioner and none on the patient. So I completely understand that perspective, and I am not going to argue with Jill Cook. Jill Cook is pretty much a tendon god as well. So I am 100% not going to argue with that. However, when does the loading come in? Again, we start loading straight away. This is working towards their tolerance. We have to find their pain tolerance. We have to find what they can do without aggravating the tendon. Again, whether or not that is eccentric load, whether or not that is slow and heavy loading, I don't care how you load that tendon, but it needs to be loaded, particularly with the Achilles. As I said, give a 24-hour respite in between shockwave and loading. That's the key. I tend to refrain from plyometric loading until they are pain tolerant. So we start to gradually progress into plyometric. I really, really do like Peter Malliaris's hot progression program. Now, Pete's program is very much designed for elite athletes, and it is strenuous. It's heavy, it's hard going, but I do like it. For those of you that aren't familiar with it, have a look at it. It's pretty much you're carrying out over 100 hops with double leg, and then that progresses into single leg, same protocol. So it's really progressive, and that's 3 times. So there's around about 300 hops in an entire training session. But that's towards the end stage, and that is there to actually get you load tolerant towards your plyometric, and you run in load and you run in capacity and increase that plyometric capacity. But what we know from the evidence is that collagen from a strenuous run, you don't actually get your increase in collagen until around about 36 to 48 hours after that run. So that's why we give you a 2-day period or 3-day period where there's no consecutive plyometric loading. So, for example, what we would do is maybe do a plyometric load on a Monday, we do a plyometric load on a Thursday, and then a plyometric load on a Sunday. But that's providing that they are tolerant to that plyometric load. And we use tolerance again as no aggravation following 24 hours, and the pain is within 3 out of 10 during those exercises and after it. I hope that makes sense.
Yeah, totally sense. Yeah, thank you. We have a question from Xian. How can shockwave therapy help for shin splints? Apply over the TA muscles. I guess it's abdominal muscles.
Yeah, tibant. So over the tibialis anterior, yeah, we can definitely work through it. It really is quite useful for pain reduction. Sometimes what you find as well is that an orthotic is quite nice for these in combination, just to offload. What you find is that they're very much heel dominant strikers because you're pulling up. You have to obviously differentiate, is this a stress fracture versus a anterior compartment syndrome, and both respond quite well. So it does really help in terms of pain and function. Sometimes we even have to look at gait retraining and move them into 4-foot runners because that then loads the posterior compartment rather than the anterior. But you've got avenues and ways to treat that, certainly as probably as a podiatrist or a physio. Yeah, definitely it works really well. There's more evidence out there. I can definitely dig out some research for that if you do need me. So if you need to question me, feel free to contact.
Okay, thank you.
No problem.
We have a question from Kyle. I think I've never heard about this pathology, so I will be interested as well. Would this be a safe and effective treatment for severe diseases?
Right. Severs. So I probably mentioned this in the presentation. There is no evidence to say that it is safe and effective for that, so we can't use it. It is a contraindication because of the open growth plate. Again, it's frustrating because we can use it for one with an open growth plate, but we can't use it for another. And we can't do it until that research has been shown to be safe and effective, unfortunately.
Okay. So we have to be patient a little bit.
Yeah, I think the ethics is going to hold that up, because I don't know how that study in Germany really had ethical approval if there was unknown potential harm to a patient. But they did, and it, with good effects. So.
Okay, thank you. A question from Deirdre Van Heerden. When using shockwave therapy, do you suggest we use it as the only treatment modality, or can you still do needling or other manual therapy and exercises?
Of course you can.
Linked to the combined therapy, or should you
100%.
just do shockwave in combination with exercise?
It's not going to do you any harm in terms of needling, etc. They work very, on a very similar pathway. It's not going to do you any harm, other than the fact that you may just waste a needle, really. It's doing a similar sort of thing, in the sense that shockwave is trying to have an effect on that neurogenic substance P reduction, and a similar sort of process with your acupuncture and dry needling. So it won't do you any harm. I tend not to. There's just because it's just not much point. I think that they're working on a very similar process, so it's no issue. If you do, great. If you don't, you're not doing anything wrong either.
Yeah. Okay, thanks. Another question from Xian. Can we apply, we talked about this. Can we apply shockwave for shoulder capsular problems?
Yep.
For example, posterior impingement syndrome.
Yes. So if that's kind of, capsular tightness, etc., and adhesive capsulitis within there. So yeah, no problem.
Yeah. Another question from Chris. The Facebook page is Shockwave. Is the Facebook page Shockwave Users Forum?
There we go. Yeah. So feel free, if any of you are DolorClast users, you can have access to that.
Okay, perfect. A question from Amarjot. What other pathologies have you used for in peds?
Pediatrics, that is. None. Absolutely none, because of the growth plates. So again, none.
And Amarjot is asking another question. Have you ever used shockwave therapy on fibromas, Lederhosens?
Yes, works very, very well. There is actually more evidence, I think, for focus with this. But I've used radial, and it works very, very well. Same with Dupentrons. Now, Johnny has got a case study on Dupentrons that he uses within his presentations, and it's brilliant. I think she had a very, very claw appearance within the Dupentrons within the hand, and then kind of she managed to get, I think, 3 out of the 5 down into almost full flexion and extension. So she did very well. The other 2, I think they needed surgical intervention, but 3 out of the 5 did very well. With regards to pain on fibromas, I've found very, very good outcome on a plantar fibroma. And again, I tend to use higher frequencies on it because it's a more superficial structure, so that just makes sense to me. And go towards that patient tolerance on the pain level. But I tend to put about 1,000 impulses per fibroma.
Okay, thank you, Dan. Thank you. We have another question from Taizia, and we had already this question in other webinars, I remember. Can we use shockwave treatment for an hallux valgus?
Hallux valgus, yes. It's a difficult one, because realistically, you can use it. We used to have the full approval for all arthritis changes. Whereas, because the majority of the information now is actually saying, okay, it's only used in knee osteoarthritis, that's the only approval that we have for arthritic changes. You can use it. It can be quite effective for pain relief, so there's no reason why you can't. However, realistically, it's how much effect is it going to have? What is your goal? If you're looking at it from pain relief and you're stopping and prolonging somebody from maybe having surgical intervention or an injection, if it works, great. Again, when you come back to that indication section, is it surgical or more invasive procedures, and the next phase for that patient, then shockwave is appropriate, providing that there's no contraindications. So it is doable. but it's very much experimental, not an accepted kind of treatment.
Yeah, thank you. And we have a question from Sue. Well, we already know it's a contraindication, but can pregnant ladies benefit from shockwave therapy? And but when they are, he's talking about extremities. For example, if a pregnant lady is suffering from pantaphasitis, that's a responsibility from the practitioner.
100%, yeah, and it's on you. It's your litigation, and it is a contraindication. It's a contraindication for a reason. But it's on you then. Do I think, look, honestly, do I think that carrying out shockwave on somebody's plantar fascia when they're pregnant is going to affect the fetus? No, I don't. But from a safety perspective, if anything did happen, you are responsible for that. So no, just stay away from them is the best idea, really. But yeah, it's difficult. You can't. There's no way would you get ethical approval to get it safety, because the effects of a potential adverse outcome is going to be devastating for the patient, and it's just not worth it.
Yeah. Thanks. We have a question from Cindy, coming back to the shoulder, treatment of the shoulder. For shoulder, do you do 2,000 shocks around the shoulder, or do you divide the shocks in total?
So it depends on the condition. For a calcific tendonitis, I will do 2,000 at the calcific density. And then I'll kind of put 500 into the super spin, and you can also even run down into the bicep as well with the larger head if you really want to. So that can add up to around about 3,500 impulses if you really want to work on the myofascial component. Whereas if you're doing it specifically for your adhesive capsulitis, then that is spread out over the 3 locations, as I said earlier, which is the craccohumeral ligament, your pectoralis major tendon, and then your posterior capsular on the back. And they are the 2 major kind of conditions that we would tend to treat in the shoulder.
Okay, thank you. A question from Diana: can shockwave cause necrosis of fatty tissue?
Can it cause it? Not to my knowledge. It can, as I spoke about earlier, it can actually affect osteonecrosis. To my knowledge, there's no evidence of it causing any side effects that are beyond the tendon, really. In kind of the risk of rupture is the only one, and bruising, obviously, and a little bit of post-treatment soreness, etc. Nothing to the fatty tissue. There's no evidence, to my knowledge, of any osteonecrosis being caused as a result.
Yeah, no abscess as well. Nothing.
Yeah, none.
No. Question from Andy: is shockwave safe for the elderly population over 65, considering polypharmacy and comorbidities generally?
Yeah, it is safe. Again, you've just got to be very careful with your patient selection. Not very careful, you've just got to be aware. Again, if there's a pharmacological reason for a contraindication, then it's a contraindication, you can't do it. So there's that. Like for me, you've got to be careful with the blood thinners, warfarin, aspirins, rivaroxamans, etc. You've got to be a little bit careful with those. And clotting disorders, etc., haemophilia. So you all have to be very careful around those comorbidities. But again, that's not specific to the elderly population either. You just have to be aware of them. From a perspective of kind of comorbidities, I mean, osteoarthritis is going to be in the elderly population as a general rule, and we have very good outcomes for that. So, it very much does depend on the condition. If we're looking at an elderly patient with a patellar tendinopathy, for example, you've got to query why are they getting a patellar tendinopathy? Is there something more? Is there potentially a partial thickness there? Has there been a trauma? Whereas also if there's an elderly patient who is inactive that has an Achilles tendinopathy, we then really have to start querying, okay, well, if they're inactive, is this a tendinopathy or is there a tendinosis that is really a degenerative tendon? So again, that comes into your history, that comes into the patient. Like, because listen, there's 60 and 70-year-olds out there that are running more miles than what I am. I can definitely guarantee that. So if there's people out there that are doing more activity than you, that the likelihood is that tendon, if they've maintained that activity over their lifestyle, that tendon's going to be in good nick. It's going to be in good quality tendon. So we can't specifically say that just because they're old, it's going to be a degenerative tendon. It's how well they've looked after it, and the history will really dictate that. If they're very inactive and they have Achilles pain, it's likely, is there an interstitial tear? Is there a degenerative tear within that tendon? If they've been active, again, and it's been a gradual progressive onset, it's probably a tendinopathy, and in which case that tendon's going to be in good state. As long as they, as you said, the pharmacological reasons, there's no contraindication, and the medical history, there's no contraindication. But what you will find as well, and this is interesting, the ones that are looked after themselves will probably be on less medications. So yeah, you know, it's feasible, it's safe. You just need to be aware of all of those things.
So I jump into this topic and ask if you would treat a patient suffering, an old patient suffering from arthritis. And we have actually a question from Diana asking, can shockwave be used on a rheumatoid arthritis patient? Yeah.
I wouldn't use it for rheumatoid arthritis. The reason being is that it's an inflammatory condition. So as you know, the shockwave has a pro-inflammatory effect. If it's inflamed, we're going to re-inflame it. It's just going to aggravate. So no for a rheumatoid or any other inflammatory arthropathy. So the same would go for ankylosing spondylitis, psoriatic arthritis, which are axial or tend to be axial. And I definitely know systemic lupus, all of the rheumatoid and rheumatological issues around that. I wouldn't necessarily use it for the joint problems that they would get. So I wouldn't use it for rheumatoid. For osteoarthritis, 100%, you're good. You know, for the knee particularly, that's where we know that we're able to do that. Surrounding structures, arthritis of the ankle, there's no evidence for it, unfortunately, at the moment. So it's all knee arthritis at the minute.
Okay, thank you. We have a question from René, seeing that, can shockwave be used for lumbar facet inflammation? And then would you use it prior to or after the HVLA adjustment?
Oh, right. So lumbar facets, I think. Sorry, my phone rang there, and I was ringing in my ear. But yeah, lumbar facets. Now, how do we truly establish if they're inflamed? That's the first question I'd kind of ask there. If we are looking at facet irritation, maybe a little bit of lumbar facet dysfunction, mechanical low back pain is now where we kind of throw in this as an umbrella term again. The whole argument around greater trochanteric pain is, what is the pain generator? Is it the facets? Is it the SI joint? Is it the musculature? You know, all of that is a big argument. So we don't know for mechanical low back pain. Yes, I would use it. I do use it. I have used it, and we've shown it on course that, you know, courses, the effect that it can have on people's range of motion, and certainly myofascial release techniques with it are superb. The general treatment tends to be along the lumbar erector spinae group. We do a couple of impulses, 500 impulses along the myofascial trigger points at 2.8 bar, 12 hertz, run alongside, and that seems to work quite well. If you know, it's one of those patients, if they're in very antalgic and they're very contracted within those muscles, it can sometimes relax it, which allows you then to manipulate quite nicely. The only true caveat there for me is it truly inflamed? So if we're looking at a facet inflammatory response, manipulation can potentially aggravate that anyway, as can shockwave. So I'd be hesitant if we knew that there was a facet inflammatory response going on. I'd also be hesitant because I didn't know why there was an inflammatory response going on. However, if it's just a mechanical dysfunction, which has no evidence of inflammation from an MRI or otherwise, absolutely fine. You can certainly use it. There's a specific technique that we would use. You don't want to be angling outwards because you have your abdomen deep within that. So again, it is quite depth. But I wouldn't be angling outwards. We angle in towards the spine, and we just kind of go 2.8 to 2.5 bar, because we know, again, there's going to be around about 3 centimeters of multifida in that area. It depends on the patient as well, and the fat content of that patient. Are they obese? Are they slimmer? again, that will dictate the depth that we want to penetrate, and that will then dictate the pressures that we use. But it is feasible, you can do it. It's just, I certainly wouldn't be doing it in a true inflammatory response.
Okay, thank you. Pretty clear, thank you. We have a question about antipsychotics. If you did not achieve expected results from a shockwave treatment for antipsychotics after 3 months, would you recommend to do the retreatment with a different approach in terms of number of sessions, shocks, bars, frequency, etc.?
Oh,
That's a tricky one.
it is a tricky one. For me, I would, it depends on the level of response. If there is zero response, if we haven't, I think it depends on how the treatments have gone. If the first 3 treatments have gone and we're able to apply enough energy that I'm happy with, so if we're able to get up into 2 bar, 2.5 bar, 2.8 bar, and I've applied enough energy and I'm happy with the protocol that I've applied, I don't want people to spend money on treatments that aren't going to work or that they haven't worked for that individual. So I then tend to go away and go, right, let's get on your rehab. And if we can then commence at a later date, maybe. So if they maybe start with a rehab and it's about 50% improved, we can then see if they can push it on that little bit further with shockwave. I'm just very cautious that, from a perspective of cost, shockwave is an expensive treatment. And if it's, I may be a little bit cautious with that from that perspective. You can certainly justify an extra 3, but what I tend to find anecdotally is if they haven't responded at all within the first 3 sessions, it's unlikely to improve within the next 3 sessions. So that's just my approach. You can certainly carry out the full 6 and see where you are. The difference is then, though, is that there's a difference in another 180 or 220 pound, depending on your location, in expenses for that patient. But yeah, that is, it's a difficult one. It depends on your ethics, it depends on your philosophy, and it depends on what you want to achieve. Is it justified? 100%. But equally, you could potentially start going, okay, well, maybe is there a reactive arthritis, for example, that is causing an Achilles issue? So maybe you want to start looking, if there's no response, we would expect the response. So maybe we want to start looking at why there's no response.
Okay, thank you. Another question from Diana. Can shockwave therapy be used for a ganglion on the hand?
Oh, do you know what? There's no evidence for it at the moment. Anecdotally, there is a little bit of suggestion. I'm actually trialing one at the moment. I've got a patient that's got multiple ganglions within his hand, within the wrist. First session, there was zero change. We had a discussion. We've got a shockwave trainers group, and it was a discussion on there last week. And one of the trainers there said that they've done it on a ganglion previously, and it literally dispersed within about 100 impulses. Now, mine did not do that. Like, I scanned it, there was no change, there was nothing. Are we going to continue to try it? Yeah, we will. But for me,
what's your gut feeling? Do you think it would have an impact on the lymphatic tissue?
I really don't think it's going to make a great deal of difference for them. But again, who knows? It's this person's got 3 ganglions, which is really, really strange. They've got 2 ganglions on one tendon, and then there's a deep lying joint ganglion, which is that's a larger thing. But the pain seems to be around about the tendon ganglion as well. So we've it's a little bit interesting. But we also can't rule, because I've only done an ultrasound scan in there, I can't rule out if there's anything deeper within that joint that needs to be assessed as well. So I think going to go in for an MRI with that individual. But yeah, it's not for me. I personally don't think so. But you can speak to someone else and they've had very, very good outcomes with it. Personally, I haven't. But that doesn't mean that I'm right either.
Okay, thank you. It's experimental, this kind of...
Very, yes. Yeah, very.
We have another question. Is it recommended to stick to a specific bar used throughout the therapy? in terms of, well, several sessions, or is it okay to gradually increase the bar every session?
That's what we want. We want more pressure. We want more energy. We want to get more energy into that tendon. We know that the higher energy is delivered into that tendon, the better outcomes that we're going to get. So 100% increase it if you can. Get it to always maintain within that patient tolerance. If they can't tolerate it, don't put it up. They won't thank you, and they won't come back. Go within that patient tolerance. Remain in constant communication with that patient, asking them how they feel out of 10. If it's around about a 6 or 7 out of 10, you can keep it at that level. What will tend to happen is that as the treatment numbers progress throughout that treatment, it'll become more tolerable for them. So don't push it too much for them, but certainly get it to a place where they're uncomfortable but not in pain.
Okay, thank you. This is a question from Igor, a question for ladies. If shockwave has an effect on cellulitis, and can you use it on episacral lipomas? Sorry for my English for this.
That's okay.
Episacral lipomas.
Okay. I don't know about sacral lipomas. However, from a cellulitis perspective, yes. We would use 10,000 of, again, there's been good evidence now with Chris Miller up in Manchester to show 5,000 impulses at 20 hertz. I think he even may have gone as low as, no, he didn't. It was 20 hertz, always 20 hertz with a larger applicator size. 5,000 impulses, and they were getting really good changes. It is a little bit beyond the scope of musculoskeletal, I will say that, but I personally haven't done it. I haven't set up a beauty clinic yet. But it can, it can be done. There's no problem with that. It just depends if it's in your scope or not.
True. We heard from different experts in the world that cellulitis, shockwave treatment was very efficient on cellulitis.
Very.
Some feedback from Brazil as well. Yeah,
very, very effective. It's how you justify it in terms of your scope of practice, isn't it, as a musculoskeletal therapist? But again, there's no reason why you can't do it if you wanted to. I would be tempted. I would be tempted to even just get a few patients in to trial it and see if there was a difference. Certainly in the clinic here, and just do a select number of patients and see if they found a difference, and see how it works. But from the evidence and the literature that's out there, yeah, there's very good outcomes.
Yeah, definitely. We have another question from Grant. With respect to 6,000 to 12,000 impulses used on the different types of muscle injuries listed, over which time period?
So that is in a single session. Those are 6,000 to 12,000 impulses per single session. And they are pretty much daily unless the patient wasn't available for that day or if there was no training on that day. So they are pretty much daily doses of 6,000 to 12,000.
Yeah, because it was saying, you mentioned that muscles could have more energy applied to it in a closer time period. Tendon is once a week for 3 to 6 weeks, and then possible for 3 weeks. What's your suggestion of the frequency and dosage for muscles?
So muscles, again, you can do that pretty much daily. There's no reason why you can't do that daily. Particularly, it just depends on your scope. I mean, from a perspective of, it's difficult to get a patient in daily to charge them £65 a session or £95 or £100 a session a day over a potentially 4-week period. It's going to cost a lot of money. However, you could potentially do it as a package if you wanted to, because it doesn't take long. 20 hertz, you're going to get 20 impulses a second. It's not going to take you a vast deal of time to be able to deliver that number of shock waves into that patient. So you could do it as a package if you wanted to limit the cost. If you weren't really concerned about cost, you can do it anyway. It also depends if you're in a club setting, which is what this research was carried out. Don't forget, they were also doing other things. They were doing cryotherapy. They were doing manual therapy. So it wasn't just shockwave alone that was used in this setting. So, there's probably a lot of time that these practitioners will spend with those patients and those players. Certainly working in elite sports, you spend a lot of time together and with those players. So you get to see them daily every week. You get to see them daily on every, whenever there's a game. unless there's a holidays, for example. But again, there's no holidays now at the moment. So you're seeing players daily. It's feasible to do in that setting. In a clinical setting, it's a little bit more difficult to justify that daily visit.
Yeah, thank you. Another question from Cindy. Well, it's linked to combined therapy. Do you put some of the tendons on stretch when treating with shockwave?
Yeah, interesting. Yes, I do a little bit with the Achilles, just because it depends on the location of the pathology. It just brings it a little bit more. I don't apply a great deal of stretch. I'm not really forcing it into stretch, but I will put it in so that it's taut rather than in kind of a loosened position. Certainly with the Achilles, and with the super spin, I'll bring the arm around the back so that it brings the super spin tendon more to the prominent and into the front. So yeah, we can show you that when we do the practical in probably the next 10 minutes or so.
Yeah. Maybe we'll finish with the questions. Yeah, people are asking for the practical, but yeah, we have other questions. Do you believe in your concept that combined shockwave therapy is effective rather than radial or focused alone?
So is that looking at the GDT stuff? Yeah, okay. So when we start, I mean, obviously there's going to be a full lecture in this next month. What we've looked at in the initial instances when we're looking at the combined stuff is that we know that with the addition of a laser, we can actually apply more energy into the tissue with the patient being less comfortable, so less uncomfortable. So with that in mind, then realistically, yes, we can certainly add more energy. If we can add more energy, we can get better outcomes. So it's more tolerable for the patient. Certainly, the laser works on a separate pathway as well, so it's not actually interfering with the neurogenic responses that we were talking about earlier. So yeah, we've got all of that. So yeah, absolutely. We're working on literature. There's publications that are going on in the process at the moment. I think MC, isn't it? So there is evidence that is coming out of the people, the powers that be within EMS and beyond that, in they've got access to the units, and they are putting them through vigorous testing and looking at this combined approach. So we'll know more when the combined approach literature is specifically out there. But yeah, from a perspective of what we are doing at the moment, and anecdotally what I've been doing, 100%, yeah, it seems to be providing better energies and better outcomes at the moment, certainly in the subacute stages, which is where we would use it. That's the one thing that the combined approach does allow us to do, is treat now subacute conditions with the laser combination with the shockwave that we wouldn't be able to do with shockwave alone. And equally with the acute, we can just use the laser. So it really gives us a wider toolbox, and it gives us better access and better outcomes. Again, we'll touch on this, but it depends on which method you use. You can get good, better, and best results, which we'll discuss on next month.
Yeah. And we will finish with the last question with a question from Nandu Mizo. How different or similar is the effect of shockwave therapy compared to TENS?
They're completely different mechanisms, completely different methods. As you said, shockwave is a sound wave, TENS is electrical impulses. So it's a completely different method, it's a completely different approach. If you were comparing two, you'd go ultrasound versus shockwave, as we've done in the lecture. But they're completely different methods. TENS does work on this stimulation perspective and a neurogenic kind of pathway. How effective it is kind of out there in the literature is mixed. I personally don't use TENS. I did my master's on neuromuscular electrical stimulation, which I've now started using combination with these sort of Achilles tendinopathy to apply some rehab stuff. It tend to be focused on Achilles, is what I see mostly. But yeah, it's a completely different world. There's no comparison between shockwave. They work on completely different mechanisms. They work on completely different methods. They're completely different impulses. They're completely different types of impulses. So the comparison stops really there. There just isn't there. There's no comparison between them.
Okay, thank you for this. for this complete answer. We have another question from Ulao, and then maybe we can do a short break before the practical, if you are fine with this. I understand there's a various type of shockwave heads applicators. Can you please tell us which head is good or suitable for every condition in the body region? Well,
depends. I mean, I'm happy to do that. I think, as we said, the 15mm head is what we use most of the time for all the tendons. We would use a larger one for muscle injuries or myofascial syndromes and cellulite. Now, these are the only two I've actually got for my DolorClast radial, because when I actually had my radial, the other applicators hadn't been produced yet. They hadn't been finished. So I had it very early on. But this is how they kind of come. They come in a little packet. And that one sits in there, like so. And then the other one sits on top here, there. So we also now have obviously like the acupuncture one, which is a very thin kind of needle-like impulse applicator. We have the trigger point applicator still. This goes way back. The trigger point applicator was basically trying to increase depth of the tendon and the energies that we were providing. Back when we had the radial blue, I think, or yeah, the radial blue handpiece. So all of that is now changed. I tend generally, for me, I use the two. I use the 40mm, the 30, you know, if we've got the master touch, I use the 36mm and the 15mm. But they are the two that I use daily. I mean, it says a lot that I haven't got the others and I don't use them. But they're there if you need to get deeper structures, particularly with the trigger point applicator. The acupuncture applicator is, again, trying to mimic that acupuncture effect. And that's really it, I think. I tend not to deviate from the 15mm or the 40mm and the radial, and I certainly don't deviate massively from the 15 or the 36. If you want me to get the other ones, I do have the other ones. I'll get them. They're in the other room because they're with my master touch. But I'll get you to show you and then be with you 2 seconds. Okay, I'm coming. Here we go. So that's the trigger point applicator versus the 15mm. So again, it's 15mm but longer, so we can get deeper penetration within the muscle if needed. That is an old 36mm because it's scratched, but that's the only difference there. They come with obviously the rubber bands as well, and that one is for the 15. So that's the only real one that I've got. We haven't got the new acupuncture one, which is with the radial. But again, you can have a look at that yourselves when hopefully we get to meet up at some point. But that's the only one that we've really got to show you there that is different, and that is going to be that goes all the way back to it's never been used, but it's there if you need it.
Never used because it's a long applicator, or
I just find that I just like the 15. I think that the 15mm does a job. I don't need it, and I also find as well that within my patient base, we don't need a great deal of depth. I think that from a trigger point perspective, we can work through it with the 36mm head and the 15mm head. For if you've got larger patients, then maybe you can justify it.
Okay, I think we're done with the questions. We have other ones, but maybe we do. It's noon. It's noon. Maybe we do a short break.
Yeah, I'm happy with that.
Before doing the practical session, and I know a few of you are enthusiastic about this practical session, so We are looking forward to it. So just a quick break, 5-10 minutes.
Yeah,
5 minutes.
5 minutes, 5 past,
Okay.
5 past the hour.
Okay, perfect.
Cool.
5 minutes and we come back. We are back online for this last part of the session with a practical hands-on training. Are you ready? Are you all ready for this practical session? Yes.
Yeah, I'm ready. We've got Colette sorted, so she's in position.
Perfect. Thank you, Colette, for being the nice patient today.
MC says thank you for being the nice patient today. So we is everyone back?
We have a nice question from Keen.
Go on.
Asking, where is the air compressor for the new Shockwave machine? That's the beauty of it.
Yes. Yeah, it's internal. There's also there's 2 internal compressors in here, which is how we're able to maintain the performance of the 1 external compressor. So you will probably actually hear this. I don't know if you hear it kick in. If I start it. Higher the energies that we use, the second compressor kicks in, and that's able to maintain that same energies that we were previously having. So yeah, there's 2 internal compressors. Nothing on the floor. It's very, very portable device without the compromise of the energy density or the energy efficiencies. So this actually comes off here as well. So there's a little screwed onto here. So this can be lifted off, and you can take that wherever you want. So whereas even with the Smart 20, which we had the Smart 20 portable previously, we still needed that external air compressor. And that although it was portable or more portable, it was still quite a heavy and you know, an old thing to lug around. It's a big old thing to lug around. But this is, I mean, that's how it comes, and that's how we use it. So it's quite nice that way. Right, are we all ready? Are we all ready for get onto the practical? What we'll do, we'll start with the foot and we'll work up. Claire's actually she's very familiar with Shockwave. She's a chiropractor as well. She's my girlfriend as well. I might have to add that in. That's why I'm not wearing any PPE and protection. So this is that's absolutely fine. From a perspective of plantar fascia, there's 2 ways that you can do it, and it really does depend on your setup and your clinical setup. This is how, you know, majority of the way that I can access people's feet is if they lay into a prone position, and we can just pretty much access everything there. Now, the other way you can do it is if you have a podiatrist chair, for example, and you sit in. Carl, can you flip onto your back, right? And you sit in upright or sit in normally, you can bring your feet that way, and then you can access through here. The beauty you're doing it this way actually is that you can put a lovely stretch into the plantar fascia, and you can also work right up into the distal aspect underneath the first ray. So we can do that. It doesn't really matter how you do it. I think this way is quite nice to be able to get that flexion through, and you can also mobilize the plantar fascia as you're doing it. So you could do those. There's no right or wrong. It's just however you prefer, and maybe that is limited to your clinical setup as well. So, for example, you know, I can do it. I can definitely do it this way. I have the ability to do it both ways because of the chair and the bench. Whereas if you have a chair only in your clinic, then you know you're not going to get them laying down on their front. So I'll show you this way, because this is quite a nice method of doing that. Oh, now again, this is the contact medium. The one thing with this is that it is a little bit messy because gravity takes a little bit of effect here, and that is going to run, as you can see, it's going to run down, and then we can catch that. So this is a little bit more difficult technically, but as soon as we get the sorry, there we go. As soon as we get everything on, you're good to go. Now, typically, what I do for this is I'll use 2.8 bar, 8 to 12 hertz at 2,000, 2,500 impulses. Now, that would be my protocol really, but that's the target protocol. Now, again, as I said, we always go to patient tolerance and we always work through. Now, typically with plantar fasciopathy, we'll find that it's the medial cord. It's more often than not, is it the medial cord involvement. Very rarely we can get a lateral cord involvement, which is going to come up into the fifth metatarsal base over here. Do you want to use that foot for a second for me? No, keep that one down, but there we go. So just to demonstrate, so that will run a little bit more laterally then from the lateral border, whereas this one will come all the way up to the first toe. Sorry, tickling. So let's go. So what I would tend to do is we'll pop this onto here, bring that in, and work around in a little circular fashion. And then stretch. And you can mobilize at the same time if you need to. Again, you would do that for your full 2,000 impulses. Then what you can do, which is what I've started to do quite a lot, is that we notice that providing that there's a good toe flexion through here, sometimes you can get with plantar fascia patients, they become quite limited. And we actually work right underneath this first ray. And I would just do like another 500 impulses around about 15 hertz. Stretch that through and then work down. And that's it. That is basically the two areas that I would work on with the plantar fascia. Now, of course, you can go into the calf and you can do the additional stuff that I will show you with the Achilles. All of that doesn't change because actually when we look at it structurally, the Achilles and the plantar fascia are basically an extension of one another. They're fascially connected. So you can work around on the underside and around up into the Achilles and up into the calf as well. There's no reason why you can't do that. So the one thing that you're aware of with all of that is that your impulses just start to add up. Now, again, if you're concerned about the maintenance of the machine, then you maybe want to limit those a little bit. But for me, there's no issues. There's no issues as to why we can't necessarily just increase that, and why we can't increase those number of impulses. As we said, the machine and the things are the bullets and the barrels, etc. The handpieces are guaranteed for over 1 million impulses before they need to be changed. So Chris does when we do the face-to-face webinars and seminars, Chris actually does a return on investment discussion and maintenance discussion and how much it costs per kind of impulse and whatever else. So you can work all of that out for you. But it's quite nice, quite easy. It's only going to be another kind of 1,000 impulses maybe onto the back when you're working up into the Achilles and into the muscular-tendinous junction as well. And then obviously with trigger point therapy, you can actually work right up into the medial arch. So you can actually work into the medial arch, do another 500 impulses just right into there at kind of 2.8 bar if they can tolerate it. But again, always go to that patient's tolerance. The key element for this really with plantar fascia is that we're going to be working directly onto the area of the pathology, which is more often than not that medial calcaneal tuberosity, which is where we're going to see the thickening of the plantar fascia. Okay. Now, from go to your front if you can. So from the perspective of what it's like onto Colette's front, it's harder to get the mobilization element of it in with these. But just lock this so it doesn't wheel. So it's harder to get the mobilization because I have to go under. You won't see it because of the bar, but I have to go under. There you go. I have to work here and then be doing all of that. Now, sometimes it's doable, don't get me wrong, but it depends, again, if the patient is limited to laying on their front, laying on their back, there's ways in which you can do it. So in this method, I'm going to put this up to a higher frequency for cleft just to make it a little bit more tolerable. So you can just put that on, and then you can stretch it down. That's at 25 hertz there, which is the maximum that this one can deliver to. So again, that's kind of your plantar fascia settings all done. With the Achilles, now the Achilles, I'll see if I can raise this up a touch, and then we can get a better feel of it. I'll do this one, you can see that one. I'll do that one, you closer. So again, I tend to put my knee here, so we can put a little bit of stretch onto the Achilles. Now, Carl, shuffle down a little bit for me if you can, please. There we go. So, too far, but there you go, perfect. So if we do that, we can get a little bit more of a stretch through, as opposed to, so just keep an eye on that one. So there, a little bit of a reset, and we can put a little stretch through it. It's just to make it a little bit more taut. If it's in this position and your Achilles it's hard to maintain a decent contact with the applicator. So if we bring that round, bring that under stretch, we're nice and easy just to work it through there. Let me just raise this a little. Do I need to raise it a little, or should I bring it down? Is that happy? Can you see that, MC, or am I a little bit? There we go, let's do that. Probably a little bit too high there. There we go.
Yes,
that's
the
fine.
Angle is perfect right now.
Cool.
Yeah.
So if we pop, again, a little bit of ultrasound gel or the contact medium on, pop that into there. And then we would again just go in. And just put this up again. There you go. So we're just going to work it. I tend to, rather than going directly onto this tendon, it's hard, right? They can sometimes get a reflex as well with the Achilles. So this ends up a little bit flapping a little. So I tend to work a little bit higher and then slowly bring it down to the area that we would suspect the pathology or the pain. Now, the key things, there's a couple of areas and key things that you need to work on with this, is that we want to address both the lateral and medial aspects of this tendon. Now, as well as obviously P2A, straight posterior to anterior. If we are working lateral, the reason being is that sometimes there's more of a focal lateral tendinopathy or a focal medial tendinopathy, but we want to work on all aspects of this tendon at all times, okay? So don't neglect the medial, don't neglect the lateral, just make sure that we're applying energy through all the aspects of it. Now, occasionally, what we have done is, and certainly what I've done is I've played around with this a little bit, is that I've gone, oh, do I do 300 or 500 impulses here, 500 impulses here, 500 impulses here? There's no clinical significance or difference in those outcomes. However, it's just nice to make sure that we can address all of them. If you do it 500, 500, 500, then we know that they're equally distributed. But again, it doesn't really matter massively, okay? So we're just gonna pull that on a little bit of stretch. I'm gonna start quite high, and then I'm going to slowly bring it down. Just work into those areas. And again, you want to make sure with the medial, bring that down a touch. With the medial, you want to make sure that you don't fall off. This is one of the hardest bits. I always go really close to the hand piece. Oh, I finished my impulses, sorry. I go really close to the hand piece. And the reason being, I reset then. Sorry, Carl, I just reset that to 3.2 bar. Take that right way back down to you. I know. Maybe I had a kick in the face then. So we're going to do the same. We just bring it around. Now, this is the reason why I hold it close it up here, trying to pressure down, it will fall off. So I tend to really sit quite close. You can use your hand, you can use your knee, bring that down, adjust the lateral, medial, and the same coming medial to lateral. Now, the key areas here that you want, there's a number of mistakes that we often see, is that you go too far down and you're actually just putting energy into the fat pad. So if you're looking at it from a medial perspective, this is going to be your Achilles. Underneath there, that's all fat pad. If we're angling directly down and underneath that Achilles, you're not putting any energy into the Achilles tendon itself. So be careful that you are actually, when you come medial and lateral, I guess, that you are actually within that Achilles tendon and you're not too far below it. The other thing then from general treatment of it is that we often find that there's going to be some trigger points, particularly into the medial and lateral gastro. Now for that, I tend to do 500 impulses in each of these. So wherever you find those trigger points. Now a key one that we often find with the Achilles is your tib post. That becomes quite a little bit of a problem. So Carl, can I bring you, oh, there we are, I'll do it on here, actually, I'll do it on this side. So what we tend to find is that the tib post is just going to be deep below your gastroc. So bend that one out of the way for me. There we go, perfect. So that's just going to be right under here. So right into there. Now what we will do, as to treat this, we come right the way around, and then you'll just drop off. So see how the handpiece flicks up? Just into there. Now, as we just place that there, and we run another 500 impulses all the way along, like Colette is actually struggling with that, just with the pressure of the probe. So Colette's tib post is actually quite tight in there. She's a runner anyway, so that is there. So we just put 500 impulses, we come around, and we go into here, 12 hertz, and maybe up to 2.5 bar if we can. So I'm just going to start that one. We just aim easily. We just do 500 impulses along that medial line there. So we have to go deep, really deep within. So I'm quite happy with that one. But obviously, again, 500 impulses per trigger point at 2.8 bar. Find those trigger points, find those tender points, and we can work through them. Okay. Now for insertional Achilles, this is a little bit more uncomfortable. Now I won't do it with Colette, but I'll just show you and I'll walk you through it. But because it's going to be right onto the bone, as you can imagine, now it becomes a very, very tender structure. And this is where we were talking about, you can increase the frequencies to make it a little bit more tolerable. We can actually increase the surface area of the applicator size to make it a little bit more tolerable. But there's loads of things that we can do to make that a little bit more tolerable for the patient. We want to start relatively low, as we said, and then work up. But I'm not going to do it with Carl because that's going to be quite uncomfortable. No, but it is literally put it onto flexion and work up. Now, for me, I also work from the Achilles and angle down rather than being directly on top of that. So I'll be Achilles and angling down towards that pathology at the insertion. So if you can see my angle difference there compared to being there, that's going to hurt more. But we are still able to get energy if we can do that and angle downwards. So we can still get a good effect of that, and it makes it a little bit more comfortable for the patient. So let me just wipe Colette's Achilles, and then we can have a look at the knee. But has anyone got any specific questions regarding techniques for that? Anything at all there, MC?
I'm checking the questions. We have more questions about the equipment.
Okay.
Actually, transportable. It's a question from Chris. Yeah, transportable weight for the new radial is only 15 kilos, so very light.
Yeah,
very light because there's
go
no
on to your back for
compressor.
me.
Because we had a previous question from Heath regarding the old Master Touch. With the compressor. How often do we change the rubber bands?
I'm not really sure. I change mine quite often, just to make sure that there's, if you feel as though you're, it's dropping air compression, then I would really change them quite frequently. I don't know if there is a set time frame for the rubber bands, Chris, and
Chris is saying we change the rubber bands every 200,000 impulses.
There we are. Yeah. Perfect. That makes sense. And you'll see it drop in air pressure as well, wouldn't you? So I would just change it around about that time frame. Now we're going to do patella. Okay, I'm going to just get another knee flexion pad. So we typically want the patella, for the patella tendon, want it to be a little bit of flexion around about 45 degrees. So if you bend that one there, you can get a better flexion through. So with this one, again, these are deep tendon reflexes. So sometimes we can get a little reflex through onto the patella as we continually tap away at it. Now, what I tend to do here is it's not a patella tendinopathy if it isn't at this inferior pole of the patella. It's always in this area. That's where you're always going to see a patella tendinopathy. As we discussed in the lecture, this is always in your athletic population. Every single time, this is athletic population. So, again, your patella tendon is actually quite a broad tendon, and most people just think it's finger width and it runs down. It's actually around about 2 centimeters. So it will run that. So it is quite a broad tendon. It can be between 2 and 4 centimeters, depending on the individual. And again, some of the times most of the time when we image these, that we do see focal tendinopathic points. So the same rules apply here, that we want to definitely address both medial, lateral, and kind of anterior to posterior elements of this tendon. Clet's had a patella tendinopathy. We've treated her for patella tendinopathy, and she's now pretty good. Yeah, happy with it. Running anyway, so that's always a good sign. Now, what we'll do is we will, again, just pop the gel on. As we said, it's always up into this area. Now, with the radial, obviously what you can do is just you set your tendinopathy preset, and that's away. And then you could literally do 2 bar, 12 hertz at 2,500 impulses, and you could just set it. Now, what I will do is I will show you what the analgesic button does on here. I don't know if you can see that. It's not very focused. There we go. Can you see that better?
Much better, yeah.
So if we do this, the analgesic 2, 1 bar, 25 hertz for 1,000 impulses. And that is your preset. So that's already ready to go then. Analgesic 1 is slightly different. 15 hertz, 1 bar, 1,000 impulses. Now, the ramp up doesn't necessarily change anything on your tendinopathy presets. But what it does is it ramps it up for X number of impulses. I think it's 1,000 impulses, and it slowly increases your pressure. So the beauty of this as well is your handpiece actually can increase. I don't know if you can see this. As I press that, pressure goes up. So it's really nice and adjustable. So you can do that without having access to the machine or to the unit now. So you can also, if you wanted to personalize that ramp up, you can do it from here. Whereas this is a preset ramp up, which will continue to ramp regardless of the number of impulses that are being applied. Okay, so that's the difference there with that interface. I'm going to drop that right way down. increase the frequencies, and go. Now, typically, if we were treating this and it's not Colette who's asymptomatic and doesn't actually need treatment, if we were doing someone with a patella tendinopathy, I start low. So I started around about 1.8 bar, 2 bar, just for 500 impulses generally, and then it'll start to ramp up a little bit. Now, for the 2000 impulses, then that will be kind of up into your 2.2, 2.3, 2.4, 2.5 bars. I always use this ramp up setting all the time. It's just nicer for the patient, I think, and it gets it really nice and easy into it. So that's why we do that. But we're just going to keep it off the ramp up for Colette. We're just going to work through here. Okay, so nice and easy. We then just want to work onto the lateral and around into the medial. Sorry, I'm doing it left-handed, but and upward. That is pretty much it. You do that for the full 2,000 or 2,500 impulses, however long you want to go for, or you deem it appropriate to go for on your clinical judgment. From that perspective, it's quite nice. There's not a great deal of adjuncts that you really need to do with this. You can work up into the quadriceps as well, and obviously up into the rectum if you really wanted. But we find that actually, you can do all your manual therapy stuff up here. There's no reason why you can't, but what you do find is that obviously the pain generator is this patella tendon. We need to work through that. That's the pain source. That's where we're going to get the results. Everything else up here is nice, but if you're going to focus on one thing, this is what we want to do. If you've got time and you want to add more up into the quadricep, acupuncture, dry needling, we can even put more shockwave up there into the trigger points, around into the VMO, into the VML, up into the rectum. Feel free, you can, and it will certainly help with the patient. It'll make them feel value for money. I mean, there is a suggestion in Germany that by treating myofascial trigger points surrounding the tendinopathy, we can get 20% better outcomes. So there is some suggestion of this. But again, it's not the answer. This is going to be the answer alongside your load management. This is all very nice, and that also gives people kind of a better value for money, or feel that there's a better value for money. So you can do it. If there was key areas that you're going to work into, it's the typical ones that you're going to find, which is going to be I'll show you on this knee. It's going to be around about 4 centimeters up from the joint line, or 4 fingers up from the joint line, and there's going to be a little trigger point normally in there. And then we would usually find that there's going to be a little bit of pressure up into your rectus femoris muscles. It comes up into there. And then your VML around the outside. So you can actually see Colette's ITB as we do that. You can just see that little ridge, and that is Colette's ITB. So that is, sorry, I'm not coughing, I've got a little choking on my spit. So that is your area there that we want to work into if you're going to do it. And again, if you wanted to, like you said, you can run down with a 36 millimeter down your ITB if you really wanted. That's something that we will come on to with the greater trochanter in the hip. But yeah, there's loads of ways that you can work around it. But the key thing really is going to be that kind of 2,500, 2,000 impulses into that patella tendon. That's the answer. We need to get you medial, lateral, and straight anterior to posterior, and angle up. It's no point working distally. Very rarely do you get a distal patella tendinopathy. It's always going to be proximal. It's always going to be at that inferior pole, and it's always going to be an athletic patient. Osgood fractures, on the other hand, that is down on the bottom end. So we'll move that from there, and that is always here, always on that bony path. As you come lateral, just to here, that is where your ITB attaches. This is your patella tendon attachment. This is your distal patella tendon, and this is your tibial tuberosity. And this is where you'll see the lumps. I've actually got one. I'm not going to get my legs out, but I've got one. And I have a lump here, which is from traction apophysitis, which is when I was a kid, I suffered from Osgood-Schlatter's. And honestly, it's one of the most painful conditions you can have as an adolescent. I played through it and managed to get through it, but it was not very pleasant at all. What I will say is how far the treatment options have come along now. If Shockwave was around, well, if it was more commonly used when I was 13, I would have had it. I certainly would have gone for it. However, I used like emu oils, heat balms, massage oils, ice massage. I used all of that, and it did very little for me. In the number of patients that I've treated with Osgood-Schlatter's, every single one of them have had a good resolution in their symptoms over a very short time frame. I'm talking about four weeks, really. So it's very good for it. And again, I'll show you that. It's not going to be the nicest for Colette here, but I will show you that one. Just going to do a couple of impulses for you. Now, this is, again, key thing. We go around about 1,000 impulses or 1,500 impulses at lower frequencies. So this is why we keep the impulses lower, is because we're going lower frequencies, and it's going to be very uncomfortable for someone who's got a lot of inflammatory change around this. So I will do, tell you what I will do. I'll actually do that, but I'll put it on a standoff so it's not painful for Colette. I wouldn't use a standoff. Normally I would make direct contact, but it sounds differently for you, and hopefully you'll be able to hear the actual the speed at which it's delivered. There we go. So I'm just going to leave that there. It's just floating within that gel at the moment, not the direct contact, okay? So that there is 200 impulses at 8 hertz. And I would, like I said, I'd never do a standoff for this typically, but just because of the pain levels with Colette at that level, it's not going to be nice, and she doesn't need it actually. So yeah, that's how I would treat Osgood-Schlatter's. Simple. We go up to kind of, again, to the patient's tolerance, but we start really low, build up, get that ramp up going if you need to. 1,500 impulses at 8 hertz. You could go lower, but it takes a little bit longer. But I go 8 hertz, and that's what the literature is in keeping with. And again, as I said, it's 3 to 7 sessions according to that report and that literature. I do the same protocols once a week for 3 weeks, reviewing the following 6 if needed. That's what I do, but the research is saying 3 to 6 sessions or 3 to 7 sessions, which is very much in keeping with again, NICE guidelines. So there's those. Any questions on the hip? The knee before we get up into the hip and the pelvis?
No questions on the knee.
Perfect. Good.
A question from Keen asking, what are your thoughts on MCL treatment?
Yeah, so like chronic MCL, it depends on, again, grading, specific, if there's a specific patient in mind. It does depend on the grading of the tear. If you're looking at kind of acute grade 2, I mean, there's no point. But what if we are looking at something that is a chronic MCL that is struggling you're still getting continued pain, but it's nice and stable, 100%, it's well worth doing. You can actually work straight over the joint line, not over the joint line, but over the MCL and this path. Believe it or not, the MCL is a really, really long structure. It actually comes up into the femoral condyle here, and then it actually runs down into here. So it's around about a 10 centimeter structure that it runs here. So it is a long old structure. So typically what we find is that if there's been a previous injury of the MCL, we find an irregular cortical change around here on ultrasound. And that is just saying, oh, it's maybe a bit thickened, and maybe there's a little bit of bony irregularity, but that's quite common. What we then do is under ultrasound, you can pop the probe there, and we can do a little lateral shear. If that joint gaps massively, then we know it's not stable. They don't tend to operate on MCLs anymore anyway, so there's not much point in kind of going down the referral route. We can tend to kind of do a little bit more. You can definitely work on it, work on some pain reduction, but that's it. Oh, OA knee, that's the other one for the knee. I forgot about that. We need to work on for the knee. Now, this is going to be right into the medial tibial condyle. So if I wheel you around here, there we go. So we got right into there, medial tibial condyle. And I tend to go around about 8 hertz for this, around about 2,000 impulses just directly into there. So you can work a little bit over the joint line with a 36mm head if you really wanted to. But again, you've got to be a little bit aware that sometimes there's a little bit of meniscal or cartilage extrusion around this point. Now, I literally will work directly onto that point there. Again, let's show you that one. Sorry, Carl, this is not pleasant. So we're just going to do that. I put that up in, Claire can't cope with that one. So we put that up into frequencies a little bit and do a standoff. But I would use 8 hertz for this one. So there's actually an example there of how increasing the frequencies can make it more tolerable, because I had that on 8 hertz and Colette was physically moving away. Increasing that slightly to 15 hertz has made her not want to kick me as much. But it's still, you know, it's a very bony area. It isn't the nicest in the world to go on to. But those patients with arthritis, they've had it, they're used to pain. They've had it for a long period and it works quite nicely in this area. What you do find is that it's it works quite well in the patients that have moderate to severe arthritis, not just severe arthritis that is going to be desperate for a knee replacement, and also in your kind of mild to moderate, it works quite well there. But in your mild, they probably don't even know that they've got arthritic changes, and they're probably not having a great deal of pain around there. For your moderate, that's when mild to moderate, that's when they start to get maybe a little bit of symptoms, and it works quite well for those patients. In your severe arthritis, the ones that are awaiting kind of a total knee replacement, they tend not to do as well with it. However, Coletta's actually got a patient that she's treated with tricompartmental changes and done very, very well with it. So it's worth a go if your next stage is a total knee replacement or a hemiarthroplasty. If we can do some form of interaction or intervention that's going to prevent that, we've got no problem with that at all. So you can definitely do it in those patients. But that's what the evidence is saying, that the best outcomes are with those mild to moderate and moderate to severe patients. Sorry, MC, you got a question there?
Yeah, there was a quick question from Hilary asking, what do you mean by standoff?
Right, okay, so we use these for very superficial structures. I will try and show you on my hand rather than... Okay, so if we go... here, this is obviously the gel there. Oh, can you see it? There, okay, there's the gel. Now, if we do that, there's no contact with my skin, but it is making contact with the gel. Now, as we know, it doesn't lose energy through fluid or water, so there's less, you're not going to lose energy as it penetrates. That is a full contact surface. That is going to be a standoff technique. And we use this for very superficial structures. The reason being is that it's not making direct contact with the skin, but we're not losing energy. What does happen sometimes if we don't have a proper contact, a lot of that energy will get lost, and it will actually make it almost like it'll feel worse for the patient because it slaps the patient's skin. So you can sometimes get a lot of reddening around it then. But I tend not to use a standoff a great deal, to be honest, but it's just to make it a little bit more tolerable for collective in this point. But if you are working on something, again, you could potentially do that for your trigger fingers and your fibromas, very superficial structures, you could definitely do it for those. No problem with those. But for your tendinopathies, there's no need, really. Does that make sense, MC?
Yeah, so you would use it as well for very sensitive patients as well?
Yes, 100%, yeah. But the problem with it is that I would use a larger applicator size. The problem with it is that we can lose energy at the skin surface because it slaps. It's almost like because obviously it's at that first interface. So it can get a little bit of reddening around the skin when we do that. I try not to do it if I can avoid it. I'd go every other avenue first before using the standoff. So I would increase the frequencies, I'd lower the pressures, I'd use a 36mm head before I would use a standoff for tendinopathy. But I would use a standoff potentially for trigger fingers and Dupuytren contractures and fibromas if they needed them.
Cool, thank you.
Yeah, no problem. Nothing else on the knee?
On the knee, yes, very good example. What if we do more knee flexion while you do shockwave for the knee? Example, knee osteoarthritis. Is it more effective?
We haven't looked at knee flexion. I think that if you're kind of looking at 90 degrees, potentially, you can still access the same points. I don't think that they've looked at effectiveness of your knee flexion. They have looked at the effectiveness of locations. So they've looked at medial tibial tuberosity, they've looked at the lateral tibial tuberosity, they've looked at the medial femoral condyle. They've looked at all of those as different locations, and they know that this is the most effective location. Okay.
Okay.
Yeah. Go on your side, face that way for me if you can, right? So face me then. Got a troublesome patient today. She's got a favourite hip and everything.
Come on, Colette. I'm sure you can do your
MC's
best.
giving you some encouragement. She said thanks. So with the hip, we're going to work on two areas: proximal hamstring, greater trochanter. Okay. So both of these are your favoured areas. These are the two big ones that we're going to treat into the hip. What I will do now, usually we've obviously the hamstring complex anatomy review quickly. Got your semimembranosus, your semitendinosus, and your bicep femoris. Now at the proximal hamstring insertion up here, what we're finding is that we have a common tendon, which is your bicep femoris and semitendinosus, and they attach kind of into there. Not too bad in there. Okay. So we have a common tendon attachment in here, and that's the one that the two muscles become one tendon. Now, the other one is your semimembranosus, and often this is the one that becomes a problem with regards to tendinopathy. So your semimem comes up and it actually crosses laterally onto the opposite side of your ischial tuberosity. So we angle this way when we're doing it. So we can favour that semimembranosus as a tendon attachment. We also want to work down into the musculotendinous junction because we often find that there's going to be some tendinopathic change into there, certainly into the tendon as it comes down. And you can obviously work into the muscle belly. Now, there's multiple ways that you can do this. I like doing it this way. Johnny likes doing it prone. I like to have kind of a little bit of stretch onto that tendon and bringing it a little bit more. One of the other trainers, John, as I said, Johnny likes to do it with them laying on their front and just angling straight across. You can do it either way. There's no right, there's no wrong, but I like putting it in that way. There is a consultant down by us who has the patients on hands and knees, which I think is a little bit risky. But from my perspective, side lying in this position is absolutely great. And we can also do the same for greater trochanter in this position as well, or greater trochanteric pain in this position. This is, as you can imagine, we've got a lot of muscle bulk around here. We've got your glutes that overlap as well into the gluteal fold. So we can definitely work into this area with quite high energies, and that can be, tolerated quite well. So what we want really up to 3 bar with this. We want those patients to be up into 3 bar and getting good outcomes with the impulses going directly in here. literally, I will start at 2.5, 2.8 bar and build up. I always want as much energy as the patient can possibly tolerate. So I'll show you how to go there. Again, put your contact on. Do 2,000 impulses, and I angle lateral to medial. Slow. We angle down. Again, you can just get little circles. Once you've done that, then you can work and then at 500 impulses just into that muscular tendon junction. Okay, so that is, again, how, and you can see that that's come up actually quite nice and red there with Colette. So getting a little bit of hyperemia, getting a little bit of angiogenesis. So it works quite well in that area, in this position, and it exposes the tendon quite nicely. Now, if we were to do it with Colette on her front, so do you want to go on your front foot? Same thing. We would come across and at angle there. You see that with the, yeah, we go. So we'd angle there. You can do it both ways, no issues. Again, this might be a little bit easier there to work down into the muscular tendon junction. Good. And when you're in this position, you obviously have the ability then to do the trigger points on either semi-mem, semi-10, bicep fem. So you have all of those muscles that you can work into. So that works quite nice. Let me wipe that.
Dan, we have a question. We have a question from Louise. Well, it's in the gluteal region, but would shockwave be effective and safe in treating fat necrosis and scar tissue in the gluteal region? But yeah, tricky. It's
very specific, isn't it? I mean, with regards to scar tissue, we've got to question what our goal is with scar tissue, because we don't want to necessarily break it down because that scar tissue is formed as a healing process. So we don't want to break it down because then that potentially makes it more susceptible to tearing. But is it something that we can do to modulate that scar tissue? Yeah, I mean, we could probably use the 36mm head, run through it. It depends if it's a true collagenous scar tissue, which is obviously completely different to just a healed muscle. So yeah, I mean, if it's a post-surgical, we stay away. We always avoid post-surgical scar tissue. So from a shockwave perspective, at least, it's a difficult one. It's very, very specific. I would, you can definitely work into the muscles with the 36mm head. There's no reason why you can't. From a perspective, it depends on what way you want to help scar tissue, I guess, is the question there. And particularly fat necrosis. Will it help it? Yes. Will potentially. Very potential. I don't think that there's any evidence to, again, this is going to be very experimental. I don't think there's any evidence to specifically say that it's beneficial for fat necrosis. Unfortunately, I can't give much more than that. Certainly that I'm not aware of, but I will have a little look if needed.
Okay, thank you. Yeah, that was a tricky one, I must say. We have an interesting question. Would you do shockwave for a post-operation patient? For example, fibula fracture, and also would you treat with plates inside the body? Yeah. So
plates are an interesting one that we don't want to loosen the pins of the plates. It depends how long that they've been there. And this is the other avenue that we have in terms of post-operative, post-knee replacement. Kind of if they've been there for 6 months or maybe 12 months longer, you're going to be fine. That's going to be settled and you're going to be happy days. The problem that we have with certainly screws, pins, plates is that we don't want to dislodge those screws, pins, plates. It's, you know, if it's post-operative plates removed and you want to query, see, you know, any bone pain or neurological pain, which is going to be very similar to the kind of the amputee kind of stuff, yeah, absolutely fine. If you've got, you know, fracture healing, you want to try and promote that, there's good evidence for that. We know that we have osteoclast turnover, osteoblast turnover. We know that that increases. So yeah, you know, we can definitely do it on fractures. Pins and plates are tricky. We don't want to really dislodge anything or potentially have an effect there. But for fractures that you want to increase the healing responses of, yeah, you can definitely do it. You know, there's good evidence for it. But again, it would be one of those ones that you want to be in a good setting to do that.
And what about hip arthritis?
So there's no, obviously there's no evidence to say that we can specifically treat arthritis at the moment, hip arthritis. There is for knee OA, but there is ways that you can certainly manage that. Like you tend to work on the soft tissue structures around it. There's no reason why we can't do that. There's no reason why Paul Morrissey works in London. He's an osteopath in London. And Paul does a lot into the anterior groin with the hip impingements and stuff like that as well, and that works quite nice. I have done that on a few people who seem to feel a benefit. Problem with going into the anterior groin is you obviously have your femoral artery there, so you have to be very careful not to be anywhere near that. You can certainly work on the soft tissue structures around there, which can be beneficial. And it depends, again, probably on the severity. From an evidence and literature perspective, no, there's no evidence to say that it is beneficial. But from an anecdotal perspective, it's only going to help. How long term those results are, I don't know, but it is something that, you know, you can certainly add into if needed.
Thank you.
Can I go on your side first, me? Do the hip now.
Another question. Can we? We had that one, I think, in a previous webinar. Can we use shockwave therapy for treating sciatica?
Treating what, MC? Sorry.
Can we use shockwave therapy?
Sciatica. Yeah, sorry.
Sorry for my English today.
No, that's okay.
Sciatica.
No, I tend not to. I mean, more often than not, sciatica is a disc issue, so we wouldn't tend to treat that a great deal. However, you know, you can potentially run down the soft tissue structures where the nerve is irritated, because what happens is the muscles come quite tight around that nerve. They clamp around it a little bit. So if you wanted to loosen that off, you could. You're not going to be affecting that disc though at the low back. There's just not much point really. But yeah, you know, no, not for me. I don't when I treat people with sciatic symptoms anyway. Right, your greater trochanter. So, greater trochanter is here. Let me bring you up a bit so you can see. Bring you forward. There you go. Okay. So, greater trochanter here. Now, we have obviously the three muscles that are going to play a role here. We have your glute med, which is going to be coming this way. You have your glute min that's going to be coming up. So if we look at it from an angle, glute med, there, glute min, and your glute max comes around. Okay, so let me go around the back so I can. So what we can do is we can normally I apply 1,000 impulses into each of these areas. So it would be at the kind of the anterior facet, the superior facet, and then over the greater trochanter. That's kind of where I would apply these, and I would do 1,000 impulses each. Now, it's really deceiving that how much depth we actually have here before we reach the tendon. And that is, and particularly, you know, obviously with women, there's greater depth there as well, just because of the way that the fat tissue is kind of circulated around the body. There's more fat tissue around the hip than there is in men on women. So we know that, and that's natural. That's regardless of who you are, that's a natural phenomenon. So we want to work kind of these 3 points. We're going here, here, and then on top. What you can do as well is you can certainly work trigger points up into the glute min, the glute med, so your glute med, glute min, and then work around obviously down the ITB with the 36mm head if you wanted to. So what we know about the glute max is that 70% of those fibers actually form the ITB muscle or the ITB fascia. Yeah, the iliotibial band. So that fascial connection will obviously come down to the knee. So that's why this is important with the role that it plays within the knee flexion as well. So just be aware of those. So let me show you what we would typically do. I've got another one. Oh yeah, go on, please. Thanks, Scott. So we've got 3 points. 1,000 impulses there, 1,000 impulses there, 1,000 there. Okay, and that's how I tend to put it on in the first place, in the first instance. I pop it on so I know where I'm going and what I'm doing. So we pop that on there. We go really 12 hertz, and you want high energies with this again, like I said, because we have got a surprising amount of depth. Always go to the patient tolerance, but if we can get higher energies, we're going to get better outcomes. I use 12 hertz, I'm using 20 here for correct. We'll do 1,000 at that point. Then we'll do 1,000 just there. You can see you can move it around the top as well, and you can bring it. And then we'll do 1,000 directly over it. So then you can obviously work into the trigger points, the same trigger point to kind of going up into your 2.8 bar, 15, 12 hertz into each of these trigger points, and we can run it round then down the ITB if needed. So I would use the 36mm head for running down the ITB, but you can definitely just do the trigger points as with this head. If you wanted to, for a larger patient, as we said, you can go down into that trigger point applicator. We obviously we don't need that here, but entirely up to you. I think that's it for the hip, isn't it? The hip region, that's the lower limb done there. And then we can speed through the upper limb then if needed. Is there any questions on that hip?
Not too many questions. I'm checking right now on the hip. Is it possible? Well, it's totally another question, but is it possible to get in touch with Daniel for further communication in terms of shockwave therapy? Yeah, sure.
I mean, yeah, of course. Yeah, absolutely.
Via Facebook, via Twitter, via by email.
Even if you needed to, yeah, you can contact MC at obviously at EMS, and she can put me in touch with you directly via email if needed. Then
we have a question from Chandra. What setting do you use for the energy of GTP? Great, yeah.
Great can't pain. So I will go up to obviously patient tolerance, but again, because as we were discussing with the depth of the tissue that we're looking to affect, we want the quite high energies. So really, we're going to be kind of aiming up into 3 to 4 bars as tolerated. I would use 8 to 12 hertz as well. So the lower frequencies there. I wouldn't be going down into the 1, 2, 3, 4s, but certainly 5, 8, 12. It depends on the patient tolerance. If you need to increase it up into higher frequencies, if they can't tolerate it, then do so. But I'd rather compromise frequency than I would compromise bar, because the bar is the energy. I want the energy to be delivered. I see Anna Maria has just mentioned about bursitis, and bursitis is a tricky one. Normally, can we get a tendinopathy without the bursitis? Sometimes we can get a reactionary effusion within the bursa. So what we need to establish is, are we treating the tendon or the bursa? We don't know. Normally, they 2 and 1 in the same. They do come together. So we can't differentiate. And this comes down, and this is the whole argument that we have around who, are we treating the tendinopathy? Are we treating bursa? Are we treating a little bit of and everything. And this is why we no longer call it, bursitis. It's now greater trochanteric pain, or greater trochanter pain.
Yeah. Okay, thank you. We have, I don't know if we will have time to answer all questions because we are running already out of time, but we will try to. Are there any contraindicated areas around the hip and the glute areas like they are for joint needling?
No, I think the concern there is looking at your sciatic nerve, really. No, there's nothing. There is evidence, obviously, to suggest that we can stimulate the sciatic nerve a little bit because it runs through the piriformis, which is going to be kind of in the middle of this triangle from the ischial tuberosity to the greater trochanter and up into the SI. So if I show you that, we have a triangle here, ischial, greater, and then SI. So we have that triangle, and the piriformis is usually in here. And 1% of the population have the sciatic nerve that runs through the piriformis. Now, we're nowhere near that anyway when we're doing anything for greater trochanteric pain. So it's there's no contraindications within that area beyond the normal. So that's it really. Yeah, that's it.
Okay, perfect. Would you like to show us just I don't know, quickly, if we have some time on upper limb, for example, shoulder or?
Yep, we can do that. We can do that. We can do both of those and the frozen shoulder. We can do the three of them quite quickly. Have a sit for me if you can, please. Yeah, just sit onto the chair over there. Okay, actually, let me get the chair out and then you can just rest your elbow on there. And pop your thumb down, pop your elbow on. So this is how I tend to manage the frozen shoulder, epicondylitis stuff. Let me just break that down. Okay. Actually bring that there. So I tend to have the patient sitting, as Colette is, with their arm resting on the bench. And I can just bring that up so it's relatively comfortable. So we can just bring that up into level there. She's be quite comfy there. Now, if we're looking at the lateral epicondyle, better. Yeah, lovely. So what we always find is it's always in this attachment point. So it's lateral epicondyle, and it's of the distal humerus really. The attachments, and we can differentiate with the attachments from wiggling. So if we have pain on this finger flexion, then it's going to be a specific tendon. If we have it on this finger flexion, then it's going to be the other specific tendon. Normally the pain comes up into this common extensor origin, which is going to be just there. And if you palpate that, it's normally very tender. If we have the patient just to make a fist and then push up to the ceiling, that is often also painful. So that's how we can just really pinpoint that as being a lateral epicondylopathy or itis, depends on phases and stages. So what we do, very local, go into that lateral epicondyle, press that on, and then we'll do 2,500 impulses here, or 2,000 impulses here. You can also work right the way down into the musculature. Now, we've had a few patients who have done very, very well with this. We've got one at the moment, or one previously, that was referred to me as a last resort for surgery prior to surgery. And he said, I'll give it a go. After 3 sessions, he actually had a complete resolution of his symptoms and didn't go ahead with the surgery. So that was amazing. And he was going through a lot with his elbows, I mean, because he had medial epicondylopathy as well on the other side. Now, to do the same with the medial, I tend to have them sit in exactly the same position and come around there in that way. So it's the same process, just instead of raising up to the ceiling, and we bring the wrist up that way. So bring up and down, and that is usually pain into the medial epicondyle. And we can just literally work the same thing and work up and down into there. So it's really quite a nice and easy one. Again, that is 2000 impulses, 12 hertz on both. Go as high as you can. What we have looked at on the previous the previous researches is that they used 1.8 bar with the gym equipment, and there's poor outcomes with that. And that's really not high enough. When you look at the other research that have had positive outcomes, they were looking at an average of 2.8 up to 3.1 bar. So we do want high energies, and that's going to be really, really difficult to get to, given that this is such a bony area. The one area of concern that we have here is that your ulnar nerve is literally where the applicator is now. So we want to stay on the superficial aspect of the medial epicondyle. So if we go under, that's where we can maybe create some ulnar nerve palsy. So if we can bring that there, right into that gap, that's where the ulnar nerve is, but that's where your epicondyle is. So there's a little difference between that finger, and that's the only difference in distance. Now, there's been arguments about whether or not the shockwave, there's been one reported case of ulnar nerve palsy as a result of following shockwave therapy, and that was found in South Korea. And that I actually had the head of the South Korean Shockwave Association on a course that I was doing in Cardiff once. And he was saying that they're actually arguing as to whether or not that was caused by a neuropathy, or if it was post-shockwave induced. So they're actually arguing as to whether or not the shockwave caused that in that case. But nonetheless, as it's been reported, we need to let you know of that risk. So that's that. When we were talking about the hands, there's little ones in the hands that we want to talk about. The pulleys normally are A1 pulleys. That's going to be your trigger fingers, and your dupentrons is usually up into here. Now, going low frequency in here is going to be very, very painful. So I always go high frequencies, and you can use your standoff techniques if you need at that point then. Beyond that though, the hand is very experimental. And even for trigger finger it is, but we do get some very, very good results anecdotally. And trigger thumb is right into there. So you find that tendon and the pulley is just literally there. And you can see that there's a thickening of the pulley as it overruns with the ultrasound. For the shoulder, now I know a lot of people are oh sorry, MC1.
Dan, sorry to interrupt. Would you use shockwave therapy, talking about the hand and fingers? Would you use a shockwave therapy for tube lanes?
I don't.
Tricky one, yeah.
Not really. No, probably not. I've just seen a question there from, does Daniel use radial shockwave therapy for any off-label indications? I think you've got to start questioning then what, if you are going off the cuff and a little bit maverick with things, is there justification to do so, firstly, and are we safe? So the reason why we tend to stick certainly within this boundary is that if something goes wrong, you're legally responsible. Is there any evidence to back up your decision making as a clinician? And if they're off label again, no, there isn't. So you can definitely go for a trial route, as we said, with a lot of the stuff. Like, I just tend to not see a great deal of off-label cases in my clinical practice. Doesn't mean that you can't do them. And ganglions, for example, we're trying that. I know that that's not going to be harmful to anything. There's tendons and bones and joints around there. I've tried it with those. At the moment, we're not having a great deal of response for the first session, at least. But who knows? And this is, it varies from patient to patient all the time. Post-surgical repair as well. I've seen that post-surgical repair of a nerve injury after a cut or injury. This is something I have tried, and it created a little bit of pins and needles, which is in theory a good response. But I wasn't happy with it really. Shockwave for Dicker veins is another one here. Grant has just asked. Dicker veins, it depends on whether or not we are looking at properly a tenosynovitis and what phase is that in. If it's a true inflammatory phase, again, it can sometimes be a little bit aggravating. But I tend to do it. You can do it. I think there is some research out there for Dicker veins. So yeah, it is feasible and it can be done. How effective it is mixed. but it is, you know, it is more of an experimental route, but it is doable.
Thank you.
No problem. I think there's another couple
we have
of
a question
questions.
about De Cardin. Yeah, we asked, we had already this question in another webinar. Yeah, De Cardin syndrome. I think it's doable.
Yeah, it is very much doable. John Ostrovich, Chris has just wrote that he gets some great results in the hand using focus. It's a lot more tolerable focus because we can get higher energies. So yeah. Yeah,
definitely.
There's a question here with Cindy. Have you seen that one as well?
Which one?
With BTL unit.
That's what I was reading. Yeah, the BTL. This is not the same energy we're talking about.
Completely different energy settings. So you can't use the settings that we are recommending here because the energies are going to be completely different with BTL compared to ours. So unfortunately, these are specific for EMS because these are the highest millijoules per millimeter squared that can be delivered through any shockwave or radial shockwave device. So these are specific to EMS and DolorClast, unfortunately.
So yeah, if you want more information,
so get a DolorClast.
If you want more information, either you participate in a BTL webinar or you buy a DolorClast, which is the better option.
Go onto your back for me. I'm going to show you the. Well, I can show you actually Colette's sitting. She's got the t-shirt on, so all I need is around the back for me and do me. So in this position, this brings the supraspinatus into the front. So as you bring the arm around the back, the supraspinatus obviously runs around and it attaches onto the greater tuberosity. Now it actually splits across the anterior and superior facet, so it goes facet. It looks like almost like a wedge like that. So it goes there, and the supraspin surrounds it. So it goes over the two facets. Now, typically, if we're going to see tearing, we find that right at the anterior facet. And that's also where we kind of see some calcifications. And what we tend to think is that those calcifications are kind of chronic tears that are laying down more calcium density because the collagen that is laid down hasn't really worked. So we tend to bring them into this position and apply 2000 impulses directly onto there, and this is with a calcific tendinopathy, and the same goes for your just standard tendinopathy of your rotator cuff or your supraspinatus tendon. So I tend to just bring that in, and we apply the 2000 impulses at that location there. Now, what you can also do is go directly over and down, and the reason being is that there is a supraspinatus fossa here, which is where your supraspinatus muscle sits, and you tend to find that there's going to be a lot of trigger points actually just sitting right into there. And again, you can use your 2.8 bar, 12 hertz, and you can run down there as well. Now, from a myofascial perspective, you can use your 36 millimeter head, start around and come down, and even down into the bicep. So for that one, we bring you into anterior, you go there, bring that round, down, and then there. So you can use a 36 millimeter head, start there, and then start all the way around and working back up. And that works quite well with supraspin, and whether or not that's a calcific tendinopathy or a standard tendinopathy, that works quite well as a fascial release. Now, the frozen shoulder one, which everyone has been asking about, is the 3 protocols, or the 3 positions. So you can have them sitting. Your coracoid process is literally here. So this is going to be your coracoid process. There's a coracohumeral ligament that runs across where my finger is. And we want to just come in and point basically that way with the handpiece. If we go this way, we're going to be into lung fields. So I always come around the front, but I'm trying not to affect your view. So we would tend to be here. That is the angle that I would like to go at with this. And that tends to transmit a little bit into the posterior aspect of the joint. We then work 1000 impulses there, 8 hertz. I tend to go for 8 hertz, 8 to 12 hertz at least. 1000 impulses at, again, patient tolerance, but I tend to go higher energies at this one because it seems to work quite well at higher energies. Then we can go the same settings, 1000 impulses along the pec insertion. Now, the pec insertion is surprisingly low. it's actually quite there. I always used to think PEC was coming up here before I was doing my sonography. And when I started doing my sonography, I realized that you can actually see that that is your common PEC here. So fibers come up here, fibers come from the lower, and they attach over here, over, literally wrapping over that bicep tendon. So we can work over that. And again, 1,000 impulses, doesn't really matter as much here. We haven't got any lung or anything to really be concerned about. But as long as we run through it, 1,000 impulses, 8 to 12 hertz, that'll be absolutely fine. Now, in the literature, it demonstrates the posterior aspects the other way. So turn and face the wall that way for me. That's it. No, like with the chair as well. So with the posterior capsule, it's here. Now, in the literature, it demonstrates we can do it with the arm in external rotation and go in straight across. So applying from A to basically this direction, from posterior to anterior, but medially. I prefer to do it to bring that over. That makes that posterior capsule far more accessible. And again, the impulses are just going to be coming around directly from posterior to anterior. And we will put them 1,000 impulses there. Again, it's angling through that joint line. So you don't want to be angling too far this way because that's going to be very bony. So if we come in and we're angling over here, rather that be in there. So that is how we would do that. And I'm going to do this very light with Colette. But you feel that in the front. If I come, yeah. So that is at 1 bar, 20 hertz. And Colette was like, that's quite deep within the joint. So we know if you're too far over here, you're not really getting within that capsule. If you angle that right, you can just feel that joint capsule is going to be right in here. And again, that should be quite deep there. Yeah. So that's when you know. So ask those questions to your patients. Can you feel that in the front of your joint? Can you feel it in the joint? Is it deep? Is it more superficial? And that's how you know that you're within that joint line then. So that's a good way that you know for the frozen shoulder. Is there any other kind of protocols or anything that you want to go through? Because I think that's the majority of them.
I think it's fine. We went through all all different kinds of indications, all areas, and no, that was brilliant. Thank you so much. And we have no more questions, so I know that you did a great job. Thank you, and thank you, Colette.
Thanks, Colette. No worries, she said. Thank you, MC. Thank you for having me. Thank you guys for listening. I know that it's been a long morning, but thank you very, very much.
It was a long morning, but it was a productive webinar. Thank you so much for your expertise and the detailed protocols. It's all the time. Each time I have a webinar with you, I always learn something. So and it's, I think it's also we have nice comments from participants. So thank you all for your participation. We will have another webinar next month on the 20th of March on the GDT, on the guided DolorClast therapy. So based on the combination therapy. So please stay tuned, and I will send the registration links soon, very soon. So stay tuned, and thank you again, Daniel. Thank you for this long webinar, and I wish you all a great weekend and a great sunny weekend here in Switzerland. I hope you have too in the UK. And take care, and see you next time online next month.
Brilliant. Thanks, MC.
Thank you. Bye-bye. Bye-bye.
Thanks, guys. Bye.
Thanks. Bye.